A very good afternoon to all of you. Yet another afternoon, we are all here. So I think we are going to learn today new angles, new things for the day. So let's share the topics which will be discussed today. So topics for the day will be follow-up visits, what to ask and how to decide next step in the treatment of acute and chronic disease, study of materia medica and repertory from different angles, and how to utilize them in the treatment of practice. And all delegates can raise their hands if they want to speak something, so we can unmute them. Over to you, sir.
Okay. So, follow-ups, right? What exactly is a follow-up? It's very easy uh, in homeopathy. First of all, good afternoon to everybody. And I hope this Sunday, after a lunch, you all are not feeling sleepy, because generally there is this habit of having a very heavy lunch on Sunday afternoon and after that sleepy. So at least if any one of you becomes asleep and you are snoring, please mute करके रखना, because if you unmute and I hear snoring, then that will depress me. Nonetheless, follow up. Actually, what is very important to know, what constitutes a follow up? A follow up, to my mind, is all subsequent meetings after the first prescription has been made. After the first prescription has been made, not after the first case taking. Because many a times I've seen in my practice, at the end of first case taking, I'm not sure of a medicine. So we prescribe a placebo, or we ask the patient, we say that, no, you wait at this point of time, we'll see you up after 7 days, or we'll see you up after 15 days. Or many a times it also so happens that at the end of the first case taking, you find that the patient has received some homeopathic medicine, say maybe 7 days and 10 days back, and it is not prudent to give a medicine right now. So you wait. In such a case, when the next time the patient comes, that actually seriously does not become a follow-up. It is still you are in the realms of the first case takings. And then you prescribe the first medicine. After the application of the first medicine, all subsequent visits are actually follow-ups. This is what should be the actual definition of follow-up. And here you have to take one other consideration into mind, and that is, in a very discreet way, if you have a patient who is coming from another homeopath, who is coming to you from another homeopath, and he has the prescription of that homeopath. Not all homeopaths give prescriptions, right? Many of us write medicine in codes so that others cannot understand. Many of them write it in such a way that others cannot understand. And many of us don't give prescriptions. I'm not going into the rights and wrongs of that. But if you have a homeopath who has prescribed a medicine and you have the prescription, then in a way, even when you are doing the first case taking, in a way, this is a combination of first case taking as well as a follow-up. So you have two types of follow-ups. One, when it is your own patient and you are following up, that is after the administration of the first medicine. And another, when you are taking up the patient as a new patient, but this is a patient who has received a homeopathic medicine and you have the prescription, the last medicine ka prescription you have. So actually this is also a follow-up. With these two things in mind, today we will start with the discussion. Now let me start, just a second, I'll go to a share screen thing. Share screen. Start now. Yes, but. Okay. So I'll have to find out now. Kahan gaya mera. Nitesh, can you help me? Where's my files? My files. Yes. Speeches, repertory, study of right. Wait, let it come. What's happening is, it's taking a lot of time to load. Anyway, it'll come eventually. Yesterday also this had happened. This is tiring. This is frustrating. This is really frustrating. Because the ideas are already coming in my mind. That what I want to talk of. Now you have to wait for that. Okay, there it goes, right. So we see technically all subsequent case takings after the first case taking, or rather not after the first case taking, after the first prescriptions are follow-ups. Now here there are two components. Even when you have not made the first case taking, even when you have not made the first prescription, but you have done a case taking, then in the second case taking it will be a follow-up. In a way, because if you have touched the patient non-therapeutically, if non-therapeutic intervention has been done to the patient, then you will see to it that there are certain reactions to it. In fact, if you are very particular, you will also see non-therapeutic. When you touch the patient non-therapeutically, you may see Ks's observations coming in. This you can see in relationships. You see, in a relationship where starting with a lot of problems, there are always a lot of problems. There is an aggravation followed by amelioration. That relationship is going to last for a very long time. And a relationship in which there is an amelioration first and an aggravation coming afterwards, you will see that that relationship will terminate. So don't think that Ks's observations are merely applicable to homeopathy. Ks's are, because these are laws. And since observations are based on laws, these laws are applicable universally. I've seen that Ks's observations are applicable everywhere. So from that viewpoint, if you see, then follow-up after first case taking, anything is a follow-up, because during case taking, during the first case taking, whether you administer a medicine or not, there is going to be an effect, the effect of the physician on the patient, and that is also going to produce a change. So what are the aims and objectives? Why do we do a follow-up? Okay, so basically there are, if we see, there is going to be two categories of objectives. One is ascertaining the changes brought about in the state of the patient by noting, number one, the changes in the symptomatology, number two, changes in the life circumstances of the patient, number three, changes in the general feeling of well-being and energy levels, and number four, changes in the patient's approach to life. This is what you are going to see. This is what you are, whether the case is in a chronic, in an acute condition, okay, you are maybe not going to see the changes in the patient's approach to life, because in an acute condition, the patient is not going to make a major change in the approach to life. But in a chronic condition, you have to. So once again, what? First, you are going to see the changes in the symptomatology. What are you interested in knowing actually in a follow-up? You are interested in knowing that your medicine, what changes in the patient your medicine has made, number one. And whether these changes which have come in the patient now, do they constitute a journey towards cure, or is it a palliation, or have you caused a suppression? In other words, whether your medicine selected was right, whether your medicine selected was right and is helping the patient, whether your medicine selected was wrong and it is not helping the patient, whether your medicine selected was right and initially it was helping the patient, but something happened and it has stopped helping the patient. These are the changes which you want to know in the follow-up. So basically, in a follow-up, you want to know the difference between the previous case taking, you want to know the difference in the state of the patient between the previous case taking and the now case taking in the time elapsed. And how are you going to do that? First, you are going to know the changes in the symptomatology, right? Then it is very important that you are going to find out through the patient that how is his general feeling of well-being and energy levels. Then after that, the changes in the circumstances, life circumstances of the patient, because remember one thing, as the patient improves, patient is not an is an individual, but is not only an individual, is an individual living in the society. And since he is an individual living in a society, as the patient improves, his reactions with other people is going to change. And gradually over a period of time, or maybe radically, the life circumstances are going to change. Let us take example of a classical 𝐀𝐜𝐿 patient. You will often see if you have a workaholic type of a 𝐀𝐜𝐿 patient who is working, and in his workplace, everybody is dissatisfied with him because he is finding faults with everybody and nobody wants to be with him. And you prescribe 𝐁𝐿. Now what happens is his workaholicness does not go away, but his imperfections or his perversions in his workaholicness, they go away. His fault findingness goes away. And as a result, he will be managing better with his colleagues. And now those colleagues who are opposed to him will not be opposed to him to that extent. So the patient will come. This is what my patients have come and told me umpteen number of times. You see, the patient comes and he'll tell you that nobody was giving me patta, nobody cared about me in the office, but now everybody looks up to me. Everybody, gives me a consideration. You see, the circumstances have changed. So the life circumstances of the patient are initially, now when they will change, they may not change immediately after the first prescription. We had a patient. In fact, we are having a patient right now. The patient was so self-centered that you cannot even imagine. The epitome of selfishness. And she has a hypothyroid problem. She has a heart problem. She's with us. She's on allopathic medicines and she's with us since a long time. Recently, she was a person, she stays very close to our clinic, but she was a person that she would not wait even. By chance, if we said that the next patient is in a hurry, if we see her, do you have any objection? She would say, no, I have to go. You have to see me. That kind of selfishness, where she could easily adjust. She was not that type at all. Recently, you would be surprised that January is a time of celebration in West Bengal. 14th January, we have certain sweet dish preparations. Those are called pites. So first week of January mein hota hai. She prepared those and she brought it to us. She has been a patient for last 2 to 3 years. Never has she done that. The other day she prepared matar kachoris and aloo dum, and she said, when I prepared it, see now these change which has come into her. You have to note this change. You have to take into care. You have to take into account this change, because this is a very important change. This tells you that the patient is improving. You see? Okay. So changes in the life circumstances of the patient and changes in the patient's approach to life. Now these are two different things. One is the changes in the life circumstances of the patient, and the second is changes in the patient's approach to life. You will many a time see, you must have seen this with your patients, that he is taking life in a particular way. And after the application of the medicine, you see that he now becomes more serious about his profession. Some student who was not studying properly, a tubercular child, many a times you will see that he was very restless, and as Vitulka says, you were burning candle from both the sides. There was no productivity, and you prescribe tuberculinum, and now he starts taking interest in things. He starts asking questions to mother, and he starts studying. So there is a change in his approach to life. To me, this is very important in follow-ups to note this. But basically, as beginners, our prime importance would be to note the changes in the symptomatology. And then this was one group of aim, one group, that what are we going to see as the changes. And secondly, through the subsequent case taking, suitable behavior therapy and counseling to hasten the cure. Now, this behavioral therapy and counseling, I would like to add, I would like to talk over here for a while, because see, Hahnemann has mentioned this in Organon of Medicine, where he has talked of mental diseases, that he talked
Hello, hello.
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 Hello. Can't see the screen as well as the audio is not there.
There's some problem with Sir's network. He'll be joining soon.
Dr. Akshata?
Yes, sir.
Okay, fine.
Yeah.
I'm so sorry. Something happened to the connection and
No
wait.
problem. No problem.
I'll just share the screen
Yes.
and so meanwhile, we were talking in terms of psychotherapy, right? Now, what is very important for psychotherapy in homeopathy, homeopathic psychotherapy is slightly different. Yesterday, I did not have the time of talking while we were talking about case taking, and that was in case taking, there are two types of approaches. We have studied that there is a law of similia, which always helps in bringing about a cure. And we have also studied law of contraria, which always helps us in increasing the symptoms of the disease. Right? That is what law of contraria does. So in case taking, sometimes if you want to bring out the symptoms, you have to magnify the symptoms. And in order to magnify the symptoms, you should apply the law of contraria. Because law of contraria, whenever you apply, we have studied that for diarrhea, if you give a medicine which is producing constipation, then initially the patient will feel better, but afterwards his diarrhea will increase. So the same logic has to be applied in order to get symptoms, which means suppose the patient is very jealous and you want to find out whether the patient is jealous, and the husband and wife have come. It is, and you feel that the wife is very jealous. The best thing would be you look at the husband, as if you are talking with the husband, and with the corner of your you are talking with the wife. Ask the wife that, are you very jealous? And with the corner of your eyes, you are looking at the husband. The wife will say, no, I am not at all jealous. And the husband will say, what? He will look at the wife and say, she's not jealous, she's saying. And the cat is out of the bag. So there you use contraria. But in order to cure, so when you are using a psychotherapy, in order to cure, law of similia has to be used. And we use this many times. See, you will see, sometimes if a person is in a great sorrow, I've seen this many times happen in our clinic at 44KR. The patient has lost somebody, has lost a mother, and is in great sorrow and is crying. And at that point of time, we stay with that person for a while. And then I start, when the person is looking up to me as an important individual, I start talking of my sorrows. And to be very honest, sometimes you even make it up. You have not had a sorrow like that, but you create a similar circumstance. And gradually you will see that the patient in front of you was sitting slouched down, and you see as if he's gradually become better. So when we come to this, to suitable behavioral therapy and counseling sessions, these have to be done on the basis of law of similia. These have to be done on the basis of law of similia. How to do them? I gave you one example. There can be many examples like this. This is what we do in the clinic. You can try it out, but this actually has to be learned from, at least let this idea percolate, that through the medium of case taking, you can also, by applying law of similia non-therapeutically, you are applying law of similia therapeutically through medicine, but you can also apply at a mental emotional level law of similia non-therapeutically, and that will also bring about, that will help if your application of the law is proper, if you are using yourself as a medium, proper medium, then that will also help in hastening the cure. So these are basically the aims and objectives of subsequent case taking. Now with these objectives in mind, you're going to see what are the changes in the symptomatology. So for that, one thing is very important, that you should have had a case record. You are running a busy practice. There are many doctors who are running a busy practice, or they have a small chamber, they don't have time to keep case records, so they don't keep case records. In homeopathy, this is a criminality. All you have to do is you have to see Handyman's case records, how meticulously he kept his case records. If you can see Ken's case records, you will see how meticulously he kept the case records. Because these case records of the patient, these have to be kept, however you keep them. You can keep them in a paper form, you can keep them on with computers, you can keep them on electronic media, whatever way. Because unless you have a case record, you will not be able to find out what are the changes in the symptomatology. And over a period, maybe within 1 month's time, you will remember. And that also you won't remember. If you are running a busy practice, say if you are seeing 45 to 50 patients a day, after 1 month, when the patient comes back, it may be difficult to remember the patient, unless you are blessed. I've seen some patients, some physicians who even after 30 years, when the patient walks in, their memory is so sharp, they know and they remember the patient's name. But not all of us are like that. We tend to forget. So you have to have an efficient case record system. And when the patient comes on the subsequent visit, you are going to go through that case record. That is a must. Because unless you have a case record, how will you know what are the changes? You will have to just go by the patient's words, patient's mouth. I'm better or I'm worse. And by that time, if a new circumstance has come in the patient's life and the patient is worried about that, so the patient says, I'm better, I'm not better, and you think that the original case is not better, and you mess up the whole case. So that is not allowed. That is not allowed in homeopathy. Homeopathy is the artistic way. Okay, is an artistic way of applying a scientific principle. So you cannot take things for granted. You have to do what has to be done. No, I don't have measures to do it. Somebody might come and say in a charitable, how will I, yesterday for example, that doctor was saying that she goes and sees Adivasis. So maybe she's seeing a lot of, now if she says I cannot keep case records, that is no excuse. You might be doing good work, but you will be desisting from doing homeopathy in its best spirits. In its best, you will be still doing homeopathy. But what homeopathy is actually capable of delivering is not possible unless all steps are followed correctly. If you compromise with the steps, you will be compromising with the results. I've seen this umpteen number of times happen at 44KR. I make mistakes and I learn from them. So you have to have a case record system. On the basis of the case records, previous case record, you will note first aggravation and or amelioration of symptoms. That means symptoms which were narrated by the patient at that point of time. They may be presenting complaints, whatever. Go case taking back, whatever that case taking had, you go one by one. Then you inquire about disappearance of symptoms, reappearance of old symptoms, and appearance of new symptoms of importance. Because if your medicine selected is wrong, some new symptoms might come in. Even if your medicine selected was right, and the next medicine is coming in, then also some new symptoms of importance might come in. Yesterday we had somebody had asked about relationships, and we had said that Rustox and Bryonia. We had said Bryonia and Rustox. Right? So Bryonia is an aggravation from motion. And after that, the patient is better, and now you have aggravation from first motion and amelioration from new continuous motion. See, this is a new symptom, and the previous medicine was right. So that might happen. So you have to keep a track of this. So first is aggravation and amelioration of symptoms and or amelioration of symptoms. This can happen in any ways. This can happen, symptoms are aggravated, some symptom is aggravated, some symptoms are ameliorated, or some symptom was aggravated first and then ameliorated, some symptom was ameliorated first and then aggravated. Either ways, in all combinations, Because what is very important is once you understand the chain, then you will be able to. What is my aim? My aim is to know whether the patient is curable or not, whether the right medicine has been given to him or not. This is my basic aim. And what do I need to do now? Because if I've given the right medicine, am I to wait? Am I to go to the next higher potency? If I've given a wrong medicine, am I supposed to change at this point of time? If I've given a right medicine and the medicine has acted, but now the symptoms have changed, then is it the time to give the next medicine? These are the things which are in your head when the patient comes to you for the next visit. And this brings in a question that ideally, when should the next visit be? In an acute condition, in an acute disease, in an acute individual disease, 24 hours is enough for one observation. What I'm meaning is that at the end of 24 hours, you can do a subsequent case taking. But the same thing if you do in a chronic case, it is not going to help you. In a chronic case, if you do a subsequent case taking at the end of 1 week or 2 weeks, that is also perhaps not going to help you. So here, what the stalwarts have said, and I go by what my teacher George Vitulkar says, that in a chronic case, subsequent case taking, if the symptoms are not very troublesome to the patient, subsequent case taking should be roundabout after 4 weeks time. And even if it is after 2 weeks time, let it just be that you are doing case taking for the sake of case taking, but don't come to any conclusion. Because as long as 𝐾𝐻's observation, we'll be doing them later, as long as 𝐾𝐻's observations are not over, you cannot come to any conclusion. So the period of subsequent case takings are very important, and that has to be kept in the mind and the heart of the physician. Because many times I am accustomed to see a patient after 4 weeks time, and for some reason if I see a patient after 2 weeks time, and if I apply all the principles which I applied 4 weeks time to 2 weeks time, I might come with a mistaken erroneous conclusion. So this has to be kept in mind. So you're going to note aggravation and or amelioration of symptoms, whether the aggravation, a group of symptoms may be aggravated, the group of symptoms may be ameliorated, etc., etc., etc. Disappearance of symptoms we talk, reappearance of old symptoms we talk. Then the third point which you are going to see, and this is from this point onwards, it's going to be a little bit difficult for students who have not studied under Vitulkas, because we have not been taught like that. And that is, you have to see the change in the nature of the so-called disease and the nature of symptoms. Meaning, over a long period of time, you will see. Yesterday, we touched on this point very briefly. We said that at one category of vitality, there are patients who are suffering from acute diseases and no chronic or latent chronic. Whereas on the other spectrum, other end, are those patients who are suffering from deep-seated chronic ailments and no acutes. Now, as it progresses, as the patient progresses, from the lower end, he will gradually, there will be a shift to the left. So first I said acute and no chronic. If that patient is on my left side, that vitality if I place on my left side, and deep-seated chronic diseases with no acutes on my right side, you will see that when you apply the medicine, the vitality will shift from right to left. So there will be a change in the nature of symptoms. There will be a change in the nature of diseases. For example, group 3 patients, group 3 lower patients, that means a patient who had a deep-seated chronic and no acute. When you start treating him, what is going to happen is, gradually over a period of time, his chronic state is going to diminish a bit. The symptoms might diminish, and now he is going to have acutes. He's going to have mild acutes. So when you see this change in a patient who was never having acutes and had a deep-seated chronic, And after the application of a medicine, you see that his chronic state has gone down a bit. And now he has acute diseases once in a while, but they are of a very mild nature. This should tell you. You are going to note this change. And if the reverse occurs, that means the patient was having very frequent acutes or very severe acutes, and his chronic state was there. And now after treatment, he has no acutes, but his chronic state has deteriorated. Let us give an example. A child is coming to you for easily catching cold tendency, and you are treating him, you are giving belladonna, then maybe you are giving him calcarea, you are giving silicea, you are giving tuberculinum, and then all of a sudden you see that his cold tendency has gone away. You feel the parents are very happy. Every month the child had to be given antibiotics. Now we don't have to give antibiotics. And then you see that the child is becoming restless. Child is becoming inattentive. The child develops a constipation. You see, all chronic states are severe chronic states pertaining to the very central being of the individual are taking place. So the acutes have diminished and the chronic has increased. Now this is a reverse direction. So this has to be kept in mind. In the initial phases, since we are not very well equipped to handle with this, do one thing. Today is a Sunday, you won't be having patients today, most of you. From tomorrow, when you go to your chamber, try to take this point also into consideration. Maybe first 1 month, 2 months, 3 months, you will not understand, but gradually you will understand. And this is a very clear-cut indication of whether your medicine is selected, whether you are going in the right direction or not, whether you are going in the direction of cure or whether you are going in the direction of palliation or suppression. So these 3 things have to be taken into consideration. Right? Are there any questions over till this point of time? There should have been some questions. So let me. We'll take a small. Are there any questions? There are no questions. Okay. So let me go.
Sir, one question.
Yes.
Sir, if the patient is having a complaint and is starting after taking medicine that the old symptoms are appearing, and these old symptoms are most irritating and difficult to the patient, and patient is having a continuous complaint, then how long shall we have to wait, and what we have to do?
You have to wait. You have to wait. You don't have any other options. You don't have any options. There are only two things open to you. One is you have to wait till old symptoms come and they go away. There will be times, however, when old symptoms don't go away and they stay with the patient. At that point of time, it has become a constant thing, not the irritation, but if it is not diminishing any further, then at that point of time, you have to do a case taking and you have to see what medicine is coming in and help him with that medicine, or maybe repeat the medicine in the same potency or a different potency. Otherwise, you cannot do anything. Believe me, I'll tell you a case of mine. We had a bronchial asthma patient to whom we had given, and this was a child of 4 years or 5 years, we had given graphitis. Graphitis 30 or 200, I'm not very sure. We had given 2 doses. It was either 30 or 200. And then the child, the skin eruptions, the bronchial asthma disappeared and the child developed skin eruptions. And this became so severe, you won't believe it, that after a particular time when I used to visit the child, the moment I would enter the room, there would be that typical bad odor of skin eruptions, of putrefying flesh. And the eruptions had become so putrid that the child had to be covered in a gauze piece. The whole body was covered in a gauze bandage. And that lasted for at least 3 to 4 months. And we did not change, we did not make any change. That child was a bronchial asthma patient who could not do without steroids. After the skin eruptions were over, after the skin eruptions healed over, He was totally a new person. So that you will have to wait. That is, it will be irritating to the patient. It will be irritating to the physician also. It is very irritating to the physician. But a physician, Kant used to say one thing over here, a physician who is the laws, who knows the laws, he knows that these old symptoms are coming, are very good. So he will be jumping in delight. And if he is jumping in delight, he will transmit this jumping in delight to the patient, and the patient will bad with him. The patient will bad with him. If the patient does not bad, there is no way. If that old symptom is suppressed, mind well, then you will make the patient more incurable than he was at first. Because see, what are these old symptoms? You have to understand, as the disease was progressing, each level which was suppressed, when the disease progresses, when the sickness progresses, Herring's law of cure is going in the reverse direction. So from less important to more important organs are coming back. Now, when the symptoms, when the cure takes place, from more importance is going to shift to less important. So the old symptoms are always going to be of lesser importance than the previous symptoms. They will never be of greater importance, but they may cause more irritation, more discomfort to the patient. But since they are of lesser importance, if you show this to the patient, that at least this is better. Suppose if the patient is having a skin eruption and the patient was having a heart problem. Now the heart problem is gone and he's having a skin problem. And if the patient shouts too much, you can always say that, is it better that you have a heart problem and you suffer for the rest of your life with features of congestive cardiac failure, or is the skin symptoms better? If you show this to the patient will understand. But here the thing is that the doctor himself, he has to know what is happening in the case. If you don't know, most of the time what happens is we make mistakes because we don't know what is happening in the case. Because we don't know, that is why we want to jump in and to treat symptoms. Homeopathy is not treating symptoms. Homeopathy is treating the totality of symptoms. Is actually not even treating the totality of symptoms. Is treating the patient. So don't jump in to give relief to one or two symptoms which are troublesome. Because as the logic says, just think about it. What old symptoms are going to come back? Not all old symptoms come back. Why do old symptoms come back? Have we ever, as physicians, as a student of homeopathy, have we ever thought that where is the need for the old symptoms to come back? The old symptoms must come back in order to cure. A cure is not possible if the old symptoms don't come back. So they are going to come back, but they are going to be less important. Always remember, you will never have a gastric problem going down and an old symptom of heart coming back, because that is not the course of sickness unless it was complicated with medicines, right? So you have to wait at that. Okay, then after this, other than the changes which we talked of, the physician has to see the changes in the general feeling of well-being and energy of the patient. See, many times you will see the patient will say, I'm feeling much better. I'm feeling much energetic. Patients come and tell me, doctor, thank you very much. I feel a changed person. And then I ask him that, what exactly do you mean? No, I'm much better. What exactly do you mean? Symptoms are less. That is why you're feeling better. No, symptoms are there. Symptoms have diminished, definitely. My headaches are less, but it is, I'm feeling so vibrant. See, when a homeopathic medicine acts, this is the most beautiful thing which is going to happen. And most of the patients, they understand this. So if you get this, you should try to take note of this. Then changes in the life circumstances and approach of life of the patient. This is what we are going to see. What are you going to see about this? There are two things. One, now this part, one of the parts, since you will not be doing it yourself, you people will not be doing it. So, but just let me touch it, let me mention it so that it will stay in your memory. Attributable to the action of the medicine administered. The example of 𝐾𝐜𝐿 which we gave, right? Because 𝐾𝐜𝐿 has acted, the patient has changed, so the patient's Circumstances have changed, the patient's approach to life would also change. Secondly, is attributable to the changes made by the patient on the basis of his or her changed perception after the first case study. See, we are talking of non-therapeutic treatment. Now, that non-therapeutic treatment is going to touch the patient. It is definitely, it touches my patients. And the patient is going to go home. Not all patients, but some patients are going to go home and think. I've had many students, when their parents tell them something, they don't do it. And that is why the students' parents at times get angry at me. They don't do it. But when I tell them, they go home and they start doing it. And when the parents say that, I used to tell you, you never did this, they say, no, sir says you are supposed to do it like this. See, this is the change brought in them, and they are not all of them are my patients at that point of time. This is the change brought about in them because of the interaction. Your interaction at the time of case taking, if it is, what is the word? If it leaves an image, if it leaves an imprint on the patient's heart, on the patient's very being, he or she is going to think about it and is going to make certain changes. So these are also the changes which you are going to notice. And now, so you have seen the changes, right? Right. Till now, we were seeing the changes. Now, after these changes are seen, and now this is irrespective of acute or chronic. Your subject was acute as well as chronic cases. Don't think there is any difference. There is not much of a difference. In fact, there is hardly any difference. Now, after you note the changes, you are going to analyze the changes. And this analysis is going to be put basically at 4 levels. You are going to see the Hedding's law of cure. Through these changes, whether the Hedding's law of cure is being followed or not. Now, in an acute condition, see, Hedding's law of cure, that means shifting of symptoms from more important to less important organs, going in the reverse order of the appearance. This might take in more of a time. So in an acute condition, you may not see. For example, the patient had a skin eruption. Then after the skin eruption was treated, the skin eruption disappeared. Then he had joint pains. Then the joint pains were treated and that those disappeared. Then he had a gastric problem that was treated and that disappeared. And now he has a heart problem. Now, suppose that this has taken 4 years or 5 years, and now he has come to you with heart condition. The moment you give him a medicine, the skin symptoms are not going to come back. The journey back to skin again may take around about 2.5 years or 3 years. If it is done properly and with proper series of medicines. So over a period of 2 years or 3 years, you will know that the symptoms have moved from more important to less important organs. So Hedding's law of cure is you apply over a period of time. But for instant changes, we have to rely on 𝐾𝐜𝐮's observations. Now here I would like to add, you rely on 𝐾𝐜𝐮's 12 observations, and together with that, modification of 𝐾𝐜𝐮's observations as given by George Vithoulkas. If any one of you has the science of homeopathy, George Vithoulkas' Science of Homeopathy, you will see in the Science of Homeopathy, there is an appendix. And in the appendix, he goes on to describe 𝐾𝐼's observations. What we have studied 𝐾𝐼's observations is as regards to one component. 𝐾𝐼 says the symptoms are aggravated, or the symptoms are ameliorated, only symptoms. What symptoms he does not talk. But we exist at 3 levels. According to George Vithoulkas, according to even 𝐾𝐼, we exist at 3 levels. We exist at a mental sphere, mental level, we exist at an emotional level, and we exist at a physical level. Now, what are the changes of the symptoms at each of these levels? These have to be taken into consideration. Right? So mental, emotional levels, energy levels, and physical levels. This, you analyze these changes. So this you will find in modifications of Kant's observations. Now, if we study Kant's observations, 12 observations, what each of these observation takes, Kant's observation in itself is a 3-hour, 4-hour workshop with examples and with charts, with graphs. If I show you, so it is perhaps a 3-hour, 4-hour workshop, which is not possible. But you have to apply Kant's observation, and believe me, Kant's observations are seen even in acute conditions. Even in acute condition, all you have to do is you have to note the changes. A person who has been practicing for 27 years, who has been seeing a lot of acute individual conditions and chronic states, I say with definite affirmity that Kant's observations can also be seen in acute conditions, in acute diseases. By acute diseases, I mean acute individual diseases, acute sporadic diseases, and even acute epidemic diseases as given by Samuel Hahnemann. And in chronic diseases, so they are always same. So you are going to analyze on the basis of this Kant's observations with modifications as given by George Vitruvius and others. Okay. Then you are going to see, I'm not a very big person. I am a traveler. I'm a student of homeopathy. But homeopathy has shown me a lot of things. And what it has shown me, the laws which have been shown to me, is something unique. It's something unique. And my need to share it with others is becoming so strong these days that many of my students or many of you people might think that I'm canvassing for celebrity, but it is not so. What has been shown to me, and that is why there's others, because we have seen at 44K, there are so many variations to these Kant's observations, whereby by applying this, you can say that the medicine selected was right or wrong, whether the potency was right or wrong, the dosage was right or wrong, your psychological approach to the patient was right or wrong. So many variations you can do. Homeopathy is a science. Okay, so let us not go into that. Reaction to remedies for chronic conditions on the basis of acutes as discussed by Vitruvius. We are talking of that. Shift from right to left or left to right, and energy levels of the patient. On the basis of these analysis, on the basis of the analysis of all these symptoms, all this information which you collected subsequent case taking, whether it is an acute disease or whether it is a chronic disease, you have to come to conclusion regarding certain things. One, whether the patient was curable or incurable. If the patient was curable, did the patient receive the right medicine? Was the right medicine given to the patient? If the medicine given to the patient was the right medicine, was it given in the right potency? If the patient was curable and the medicine given was wrong, how much harm has it done to the patient? Is it now time to give the next indicated? Has the next indicated medicine come? Is it clearly indicated? Is it the time to give the next medicine, or do you wait? If the patient was curable and the right medicine was given, is the medicine still acting? Do you have to wait? Or is there a time to change? Patient come to a standstill. Is there a time to change or repeat? If repetition, is it the same totality where you are going to repeat the same potency? Or has the totality shifted so that you are going to go repeat the same medicine in a higher potency? What we do is we do it randomly. You are given Netramute for headache. Headache was less. I've given 200. Headache was less. Now headache is recurring. I give 200. It does not act. Now I give Netramute 100. That is not allowed in homeopathy. And in a curable case, if the right medicine was given, it has helped the patient. But now the totality has shifted. Is it the chance? Is it the time to go to the next medicine? And next medicine, what medicine is to be given? Or do we still wait? Always remember, a shifting totality is no totality. As long as the totality is shifting, changing, it is not a totality. Once it comes to a standstill, you have to wait for some time. This was curable cases. In incurable cases, have I given the wrong medicine? In an incurable case, if you are given a right medicine, then how are you going to follow it up? These are the conclusions which you have to come to, and then act accordingly. Whether it is an acute disease, whether it is a chronic condition, chronic patient, it matters little. In an acute disease, you are not going to get reappearance of old symptoms so clearly, because actually you are going to get, but the patient may not be so careful about his development of symptoms that he will tell you. For example, a patient has 𝐾𝐜𝐻, then he has sneezing, then he has fever, and now with fever he comes to you and you give him a medicine. He's not going to backtrack to 𝐾𝐜𝐻. It may backtrack, the whole symptoms lot may disappear, or his fever and sneezing may go away, and he might have 𝐾𝐜𝐻 for a day and it might go away. That he might be there to tell you, or he may not tell you. But so that will not happen. But the aggravation, amelioration of symptoms will happen. Observation number 3, observation number 4, you are bound to get. You will definitely get. Or your medicine is wrong. The moment you give, I had given for fever, a patient had come to us. Those were my early days when one of my teachers in the college, he had said that if you don't understand anything about fever, then give the patient belladonna, and you will see wonderfully belladonna, the fever goes down. Now that was there in my mind, and the patient came to me and I did not understand anything about the fever. So taking name of that teacher, we prescribed belladonna 200. Okay, and we gave a dose in the chamber, and we said, go home and report to us after 24 hours. So after 4 hours or 6 hours, the parent calls me up and he says that the child is much better. The fever has totally gone. Thank you very much. I said, okay, don't give any further medicine and let us see. And then again, after 2 hours, he calls me back. He says, when we brought to you, the child had a temperature of 102. Then the fever had gone, and now the temperature is touching 104. We have given him Calpol. Now what do we do? So you see amelioration followed by aggravation. And I realized that my belladonna was wrong. And then we worked up the case, and ultimately the next day something happened. So you want to get it in acute condition. My only contention to you people is that don't be hypothetical or don't be critical about, do we get 𝐾𝐞's observations? Do we get Hrig's law? When is the time to get 𝐾𝐞's observation? What about Hrig's law? वो सब बोलने का बात है. Don't do that. Because these are the only tools which will tell you whether your patient is becoming better or not, and whether the medicine which you are given is the right medicine or not. So I rest with my first topic. It's 5 minutes to 4, 1 hour. Are there any questions? Or do we move to the next?
Sir,
do we move to, tell me.
So how do we know the medicine is acting, and do we get result in within few minutes or?
Instantaneously, boss. In an acute condition, if your medicine selected right, is instantaneously. If you will get. That will depend upon the vitality. See, I'll tell you. I'll give you an example. How many participants are there in this this seminar? Say, I don't know. I'm not checked up. How many, Dr. Akshata, how many participants are there?
67.
Right?
Yeah.
How many?
67.
67. Okay, fine. So 67 participants are there. Now, what I've been talking of, for one person, his or her whole life would be changed entirely. For one person, there will be no change. So you see, this is totally, whether the changes which you are going to see, what changes you are going to see will be dependent on the vitality of the patient. But the changes will be instantaneously. The moment your medicine starts acting on the vitality will produce changes. But whether you understand those changes, you are capable of understanding those changes or not, is a different thing. I'll tell you, we had a patient who was suffering from fever, febrile convulsions, 104 point something, and was having convulsion. This was once again a child, and was brought to our clinic, and we prescribed the medicine. And you won't believe this. The moment we prescribed, there was no change in fever, there was no change in convulsions. But the child was moaning. The moaning stopped, and the child went to sleep. We had a status asthmatic patient. You know what a status asthmaticus is, right? Now, we had this patient who was on oxygen, who was on steroids, and was not responding to treatment, was very restless. We went to his house, we saw the patient, and we prescribed the medicine. And I was, after prescription of after giving the medicine, I had taken my medicinal box with me. After giving the medicine, I was putting the medicine in the box, and I was thinking, how long do I sit? I mean, do I go out immediately or not? And to my surprise, I saw the patient going to sleep. It was not even 1.5 to 2 minutes. I've seen an unconscious patient. Now these are all chronic states I'm talking of. Status asthmaticus is a chronic state. I've seen an unconscious patient that we put the medicine in. वो खैनी जैसे खाते हैं ना? You eat खैनी. I mean, you part the lips and you put खैनी there, tobacco there. So we parted the lips and we put in between the teeth and the globules. And I was waiting, and the person started making sounds, and the person was up. So the changes which are going to happen, they are going to happen. First, you have to be observant enough to see those changes instantaneously. The vitality will take some time to show you the changes. Now, if you can't see those changes, that is why we said that on an average, for an acute disease, 24 hours is too long a time. Within 24 hours time, you will know the changes. If the patient is curable, the patient 24 घंटा में ठीक हो जाएगा. My fever cases generally, they don't last for more than 24 hours. And by 24 hours, if the fever is still there, I know that my medicine was wrong most of the time. Not in all cases, but most of the time. Okay, we are talking of acute condition. In chronic condition, 1 month is enough to let you know the changes. Maybe in a chronic condition, when you're given a chronic medicine, next day you may not understand what are the changes, but an expert will. I will tell you a case of my teacher, Reverend Maharaj. He's no more. There was this patient to whom patient was having dysphagia and was suspected to have an esophageal carcinoma, but the patient for some reason or the other would not undergo a esophagoscopy. He said, no, I will die if I have an esophagoscopy. I'm not going to go in for esophagoscopy or whatever. So he gave a medicine and he said that you will be able to eat properly. No issues. The lady came back after a week's time and she said, there is no change. I cannot eat. My boss, he just touched her. He just touched her and he said, you are better. Any day you have changed. And he started saying the changes which had come to this lady within 1 week's time. And I was totally dumbfounded. He said, you are sleeping well. You were talking, you used to talk nonsensically. You used to talk always. You used to eat your husband's head off. You have started doing that less, which the husband collaborated. Within 7 days, by just touching the patient, he could do it. I could not do it at that point of time. So there are two things. One, sufficient time has to be elapsed. One, and second is how well you develop yourself. And this developing yourself never stops. It never stops. Does it stop? No, it does not stop. It does not. It did not stop with Haniman. That is why Haniman, even at the time of his death, just before his death, Madam Melanie told him that I am tired. Haniman says, how come you are tired? How can you be tired? There is no place for tiredness. You have so much to go. Go ahead. So, okay. So that was it. Are there any, can we go to the next?
Thank you, sir.
Hello, sir.
Yeah.
Yeah, sir, I have a question. As you just mentioned in a few minutes before about your case is bronchial asthma. You gave in that case is graphitis, and after that there's so bad eruptions appeared on skin.
Yeah, that graphitis case you were talking of.
Yeah, in graphitis case. So
Yeah.
as skin was so bad for the child, so as we mean for those are the very young practitioners, so not very easy to cap that person on that situation.
Yeah. But then, yeah, I understand. But I was very young at that point of time. Huh? I was into second year of my practice at that point of time. When I did this case, I was equally as young. How many years you have put into practice?
Sir, actually, I'm right now I'm in the UK. So for the last.
How many years? Okay, how many years have you put on in practice?
So here I'm practicing for the last 3 years, but in India, around 15 years before I practiced.
Okay, 15 years. So in India, you have practiced 15 years. I was in the second year of my practice when I did this case. See, what happens is, I'll tell you something. This is what happens to me. I don't know whether this will happen to you or not. When I know, let me give you an example. I'll like to give you an example. Today, suppose I'm in need of money, and my father is a very moneyed person, right? In that case, him having money will boost me up. It will give me a lot of confidence. It will give me a lot of strength. It is the same thing which happens to me when I know that I am working on the laws. On the basis of the laws, when I am working, that gives me an additional strength. And somehow it so happens that when I am very confident, I am being in a position to pass on that confidence to my patients. Because when the patients, in this case, patient's father, he did not believe in homeopathy at all. Can you imagine a person who did not believe in homeopathy, still, because of my saying, he waited. He got transformed ultimately. So if I am confident enough, if I feel that the law is with me, if I know that I am right, I will be delighted and I will pass on that information to the patient. Now, if in the scenario that the patient does not wait, you can't do anything. You can't do anything. It is the patient's funeral. Because the patient has a choice. See, your treatment, remember one thing, you have studied aphorism number 9. Right, aphorism number 9 says that you are going to go towards, the vitality is going to go towards the higher purposes of our existence, which means that it is not only sickness going down, my dear, it is not only diseases going down. The patient is going to learn to make the right choices. And once the patient learns to make the right choices, the patient is going to stay with you. But in spite of that, if some patient does not, you cannot change. You cannot change. You cannot break the laws. The patient will go away. What to do? That patient will not be cured. Maybe that patient will come to you again after some time and say that, in such cases, what I do is, whenever I feel that this is the chance of happening, I tell them straight on the face, okay, that you stop the treatment. See, these are the things which are going to happen. You go to an allopathic doctor, these are the things which are going to happen. And they leave me. And then they go. And then when the same things happen, they remember, "Vare Baba re, that homeopath had told me that the same things are going to happen. That means he was a knowledgeable person. Let me go back to him." Then again they come back, and then if there is a chance, you won't be able to, unfortunately, you will not be able to cure everybody.
All right.
See, for curing today, for example, I have been talking of something, right? Now, there may be something which you have heard new, or something which you have heard the same, you have heard this before, but you are hearing it in a new manner. Now, you have to be willing to try it out. If you are not willing to try it out, how will you improve? Similarly, in the patient, there has to be a willing to get well. So the patient has to be willing to listen to the doctor. And there the doctor, the physician, has to say something with confidence. I mean, you ask me, you are a diabetic patient, and you ask me that, "Sir, what should be the food?" And I nonchalantly tell you, "No, you can take everything which you want." You're not going to trust me. There I have to say very definitively that this is going to be your diet. You cannot budge from this. You see?
So there is any possibility I understand the deepen to comes on the superficial layer or a less important layer. So there is any possibility we can just shift medicine onto not give it to like is a 200 graphitis and to give in some LM potencies is better if we
No.
know before.
It doesn't work out that way, my dear, my child. I'll tell you. I'll tell you something. I'll give you an example. Right now, I'm not your teacher, but I'm a speaker on this this platform. Right now, I'm giving you my ideas. At the same time, if you listen to somebody's ideas, right, without percolating, you go home, you are going to think about these ideas and you are going to come to a conclusion. But before coming to conclusion, if you listen to somebody else's ideas, which are diametrically slightly different, and because I've been talking of the laws today, if say for example Dr. Shankaran talks, he's also going to talk about the laws. If somebody else talks, he's also going to talk about the laws. But each one of us are going to talk from a different way. So before coming to a conclusion of any one person, you start hearing 3 people at a time. What is going to be the result? You are going to be confused. Similarly, when the vitality has started reacting, at that point of time, if you give any additional stimulus, whether it be in terms of an LM potency, same medicine LM potency, or a different medicine, so cannot be given. 2 medicines under any circumstances cannot be given. You are going to mess up the case. You are definitely going to. This is 27 years experience. You are going to mess up that case. What is going to happen is that additional symptoms, aggravating symptoms might go down, but the good which was going to happen to the patient will be neutralized. Be careful. So that cannot be done. And giving LM potencies, or when the patient is under centesimal potencies, once the reaction has started, you are anything which else other than waiting you do is only going to bring a disturbance in the reaction. Why do you want a disturbance in the reaction? It is not a very, very salutable thing to do.
No, definitely, sir. Once the case starts, there is no point to interrupt with another medicine or
another. So why give multiples when before the case starts? Let the case start first.
No. Sir, my question was with that is because what I understand, because I heard there is nothing is a very specific in every medical college in India in homeopathy. They teach in a specific ground. You know that things everyone
is not the issue over here. Wait. What homeopathy colleges teach is not an issue. I am not concerned with that. What I am concerned is what the homeopathic principles say. What homeopathy says. I am not bothered about what colleges say, because colleges talk a lot of bullshit.
Yes.
Let me put it on paper. Colleges talk of a lot of bullshit. In many colleges, you have multiple medicines being prescribed in the outdoors. In the best institutions, I can show you multiple medicines being prescribed in outdoors. That does not make it legitimate. So I'm not concerned with what is taught in homeopathic colleges. What I am concerned is in homeopathy, what do you do?
Yes.
Whether you are a lay prescriber or whether you are coming from a college.
Yeah. So instead of the prescribing mean, there is a no difference. We give a graphitis in LM potency or we give a graphitis in centesimal. So it's that layer is come up on the same level.
No,
That
I did not understand your question. I did not understand your question.
That is my question. As you gave
We
graphitis,
gave graphitis and there was an aggravation
yeah, aggravation. If
and shifting. Had we given in LM potency, what would have happened? Is that your question?
Yeah,
Okay.
that is.
Unfortunately, my child, I do not have an answer to that, because if I tell you what would have happened, what might have happened, that would be speculation.
Okay.
And to me, speculation, what might have happened, might not have happened. How do I know that that would have happened? There is no space. I can tell you that I had given graphitis in centesimal and this is what had happened. But I don't know what would have happened in graphitis LM. In this case, I used LM potencies in other patients. What has happened, I can tell you. But what would have again happened to them had I given in centesimals? I will not be. I will be able to guess. And at this point of my life, in such a topic, I don't like to guess, because guessing is speculating, and speculation has no, Hahnemann has said, speculation has no place in where you are discussing science. Homeopathy is a science, so I would not like to speculate.
Okay, no problem, sir. Okay, thank you, sir.
So one more question.
Yes.
Supposing a patient with menorrhagia, with uterine fibroids, if the remedy which was given helped the excessive flow for 3 to 4 months, but then the 5th month, they missed the period. So, and maybe they're going through menopause. How do we know that it's a right remedy or not?
Okay. This is okay, fine. Now, if it has helped the patient for 3 to 4 months, it would not only help the patient with the menorrhagia. If your medicine selected was right, it would help the patient as a whole. So the moment you see changes in the other parameters of the patient, you will know. See,
Yeah.
homeopathy is, it works on a all or none law. So say, for example, your patient was being palliated, right? If the patient was being palliated, in that case, the patient would not be better on other parameters.
Okay.
But if the patient is being cured, then you will see that the 𝐾𝐻's observations are being followed. That means the patient's energy levels, patient's sleep pattern, and other places the patient is improving. And now the patient goes into a menopause. You will also see the changes which come at the menopause coming. So that you should be in a position to judge.
Okay.
The crux is not always on one symptom. The crux is on the whole patient. Don't focus on when you are seeing the changes. Don't focus on the presenting symptom, whether that is better or not. That has no meaning. We have had many patients who have had headaches, and after the application of the first medicine, after 1 month, they have come and said that my headaches are worse. Headaches are horrible. What did you do to me? Your medicine did not work at all. I am worse off. And then when we inquire, we see the patient has been sleeping better, the patient has been eating better. And we know that, okay, I mean, the medicine has started acting, and this is the homeopathic aggravation part of it. So never focus on one symptom. In homeopathy, it is very, very difficult and very bad if you focus on one symptom. You should focus always on the whole patient. Through the symptoms, you should focus on the patient. Learn to do it. As you do it, don't prescribe for menorrhagia or metrorrhagia or ischemic heart disease or myopia or whatever.
Okay. So menopause, missed period, do we take as a new symptom or a fresh
Oh,
case?
you wait. You don't. If you are thinking that it is a menopause, you wait at that point of time. You see?
Okay.
You see?
Okay. Yeah. Thank you, Doctor.
Hello.
Yes.
Sir, one more question. As a young practitioner, if patient refuse to take treatment further, if homeopathic aggravation occurs, then how we can uh, just hold them so that they come to us? As you said, graphitis, it takes 2 to 3 months to go back to the normal state.
That took 6 months. Okay, fine. See, I know. See, first, my child. I understand. I understand. First, my child, you have to have confidence in yourself. You have to be supremely confident within yourself that this is a case of homeopathic aggravation and the patient is going to get it. If you are confident, then ultimately you will convince you will be able to convince the patient or the patient party. What you have to do is, yesterday we were talking about this, you have to pass on to his logic, the person's logic or the patient party's logic, that what is happening is correct and what is going to happen is better for him. So there what you have to do is, you have to learn if the patient is in a stage of homeopathic aggravation. So you have to know that when the amelioration comes, where ameliorations will come. And if you predict it, you see, you pass through this, then this will be better, and this will be better. See it for yourself. If you give that confidence to the patient, sometimes you might have to change the medicine. That means you change the medicine placebo. You change the name of the placebo. Okay, you say you had given graphitis as a placebo, graphitis 500O as placebo. Okay, I'm changing the name of the medicine. I'm changing the medicine, and you give maybe pulsatilla 200O or 500O. But if you do this, there is no other way out. You have to see. I know this is very difficult, but there is no beginner or. I told you that I did this graphitis case when I was in the second year of my practice. One of my first patients was an encephalomyelitis patient. And I had law with me. I had given him, the patient was in a coma, and we had given him a medicine. And after approximately 3 months' time, he started talking. He started singing first. So that is nothing to do with a beginner or how much are you following the laws. That is very important. You have to be following the laws dedicatedly, not half-heartedly. Because most of the times, the cases which you are talking is, you will see in these cases, if you are very sure and you have the guts to admit your mistakes, you will see that you are not confident about these cases. That is why the patient ran away. It is not that you have to be sure. I mean, if that is a disease aggravation and you call it a homeopathic aggravation, then you are stupid. And if there is a homeopathic aggravation and you are worried about it, you are equally stupid. Because homeopathic aggravation is definitely going to lead to an amelioration of the patient. It has to. Now, if the patient, so if you are confident, the point which I am making is, if you are confident enough, if you are sure enough, to a certain extent, you will be able to transmit it to the patient. If you can't, that means there is something wrong with your personality. You have to work on that part of your personality. Maybe this patient will not get well, but once your personality changes, the next patient will get better.
Okay. Thank you, sir.
Yes? So we go to the next. Do we go to the next topic?
Yes, sir.
Okay, so
Yes, sir.
now you see, 1 hour you all thought would be enough. Now you find that 1 hour to kya? Today's topic, this follow-ups, we would have talked for maybe actually 5 hours, 6 hours. Is the actual time required, and not breaking up at a time. And the difficulty over here is you can't see the speakers. You have to see them in anyhow. Okay, so selection of what is the study of material. Let us start with study of material. Okay. You guys exhausted? Any one of you exhausted? Any one of you feeling sleepy?
No, sir.
No, sir.
Thank God. Thank God. Oh my God. We are already 1.5 hours. Next time when you plan such a seminar, the better idea would be to have one subject in a day, say 1 hour, and then you have a question hour. And make it a workshop where you have a 3 days, 4 days, or maybe a 5 days workshop. That will be, because here what will happen is ideas get cluttered up. You do not, there'll be questions within many people's mind who will not be able to put it, so on and so forth. Anyhow, study of Matia Medica.
Yes, sir, sure.
Because see, the whole idea of having workshops or seminars like this is, it should be helpful, it should be, otherwise there is no sense in saying that we had a seminar where we had so many people and ultimately nobody was happy, which happens in most of the seminars. सब लोग अपना ढाक पीटने के लिए बड़ा होता है, हम तो ये किया, हम तो वो किया, which is not important. How does it matter whether I have cured a brain tumor case or I have cured a ischemic heart disease case? How does it matter to others? It does not. What matters is each one of us as homeopaths, we should be in a position to do what homeopathy is capable of doing. Otherwise, what is the sense in calling these big names? I am so averse to call big names. I don't like big names because big names are, forget it. Anyhow. But everybody wants big names. We had a seminar with this doctor. Big name. Okay, fine. Okay. So, Matia Medica. Briefly define, what is Matia Medica? It is a study of symptoms of a medicine, and various medicines are capable of producing and curing. Okay. These include subjective symptoms, objective symptoms, together with this at times common symptoms, clinical conditions, etiological factors, circumstances of the patient, etc. Right? Classically, if you see in proving symptoms, you have only subjective symptoms and objective symptoms. You also have common symptoms. But etiological factors are not well brought about in proving of remedies. It is a second stage of development of Matia Medica. So this is basically what a Matia Medica is. Now, what are the sources of Matia Medica? Those of us who have studied at the college, we have studied at college or even non-collegiate teachings, we know that classical Hahnemannian source of Matia Medica, we were made to mug up, what is the source of Matia Medica, and then we had to say, sir, drug proving, clinical symptoms and toxicological symptoms. Yes. We are made to, without understanding, we are made to mug, So these are the three classical sources, Hahnemannian sources of Matia Medica. Drug proving on healthy human beings. And it better be drug proving, proper drug trial, not the way the drug provings are conducted today in medical colleges and Central Council of Research of CCRs. It better be proper drug proving reports. So drug proving on healthy human beings, clinical symptoms, and toxicological symptoms. What are these? What are clinical symptoms? Most of us feel that we know what clinical symptoms are. So I will go by it that we know. So I will not go into details of clinical symptoms and toxicological effects. Okay. Now there is another. If you post Hahnemann, if you see, I've decided to call it neoclassical because I did not have any terminology with it. What are the sources of Matia Medica? These are based on Hahnemann's classification sources, but these are a step ahead. So those are drug proving on sick individuals, drug trials in disease conditions, speculative on the basis of etiology, and consideration of circumstances. These are other sources. For example, I did not want to go into it at this point of time, but later when we see development of Matia Medica, how Matia Medica has developed, today we can, by knowing the circumstances of the patient at times without even going into the circumstances, going into the etiology, or sorry, going into the symptoms, you can come to a selection of a medicine. For example, you have a patient who has been repeatedly, you have this girl who cannot help herself from falling in love with people. Her life circumstances is a series of falling into love with an individual and broken love affairs and suffering, and then again falling into love. This very circumstance of repeatedly falling into love affairs and each time being disappointed and then grieving and then again falling into love. You have patients who give you this history. This circumstance brings a medicine to your mind. And what is that medicine? What is that medicine?
Natromute.
Yes, is Natromute. Is Natromute. And doctor, in all possibilities, if you have this kind of circumstance, in all possibilities, your prescription, you're saying that the patient is likely to be Natromute, is going to be absolutely correct. You are not taken in terms any symptoms. You are not taken into consideration any symptoms or any other things, just the life circumstance. If this circumstance was very important to the patient. But that does not mean many of you, many of us present over here, we would have had broken love affairs. That does not mean that broken love affair, and see, when one love affair is broken, when you are involved in a love, why are you involved in a love affair? Basically, that is a need for you to be involved in an affair. So when that is broken and that need is not satisfied, you will be ready for love affair again. But that does not mean that the second time when you fall in love, this person is a Natromute. It has to be this repeated love affairs, each time grieving, etc., etc., etc. So don't think of Natromute as disappointed love. I mean, there is a broken love affair, so you give Natromute. No. The Natromute circumstance is repeatedly. And there also, if you study 𝐾𝐿 very well, in 𝐾𝐿's Mathematics, he says an inappropriate love affair. That is an inappropriate. He says that she runs away with the coachman or falls in love with a very elderly person. That kind of broken love affairs is Natromute is very tricky. Is not the classical platonic relationship love affair breaking. So these circumstances at times, not always, if you know the circumstances of medicines, just by knowing the circumstances, also you can come to selection of a medicine. That is the point which we don't have, unfortunately, as we go forward, we will see, we don't have Mathematics, we have symptoms. When we will be going into evolution, how Mathematics has evolved from Hahnemann's time, we will see. So let me go to the next. So that was what we are talking about. If we see evolution of Mathematics, the first level of Mathematics was Mathematics based on drug provings and toxicological symptoms. This was at Hahnemann's time. Hahnemann and his co-workers at that point of time, you did not have any Mathematics. Hahnemann, unfortunately, did not have the advantage which we have today of host of clinical symptoms in Mathematics. The initial Hahnemann, he did not have any clinical symptoms to work with. He had only proving symptoms. So that was the first level of Mathematics. Then what happened was, when they started prescribing medicines on those bases, gradually certain symptoms were added. Those symptoms which were cured, but they were never produced during drug provings, but they were cured when they were treated on the basis of other symptoms. These symptoms were cured and they don't become clinical symptoms then, mind well. Most of us have an erroneous idea of clinical symptoms. that clinical symptoms are those symptoms which are not produced but cured. That means, for giving an example, you are having a blister on the foot of a patient. Rustox has never produced a corn, say for example, and you give the patient Rustox on the basis of other symptoms, and this corn disappears. So corn is a clinical symptom. No, it does not make it a clinical symptom. In order to make it a clinical symptom, again, one thing has to be added. That is, this cured symptom which was not produced in some other patient, this symptom is taken as a part of the totality and it helps in cure. Then it definitely becomes a clinical symptom. So please, adding of clinical symptoms were added. So now the Materia Medica, if you see the first Materia Medica were on drug provings and toxicology. Right, at this level, if we see, we'll see heading, classical. Then with the provings, clinical symptoms were added. And that was when the next level of Materia Medica. Here also heading is included because in heading a lot of clinical symptoms have been included. Then gradually from these symptoms, it was becoming very difficult to remember all symptoms. So gradually the idea came of developing a personality. How this idea came about, and Kent was the most important person who Kent and Kentian school of homeopathy, they were the most important people who gave us this idea. What was this idea? This idea was that who is sick? It is the person as a whole who is sick. That means that instead of talking of pulsatilla symptoms, instead of talking of nux vomica symptoms, talk of a nux vomica individual, talk of a pulsatilla individual. And Kent's type of Materia Medicas came into picture, where drug personalities, drug pictures, and drug personalities came into picture. Now, these drug picture, Materia Medicas based on drug pictures, have a great advantage. And they also have some disadvantages. The advantage is you learn to recognize that individual. Today, for example, if you have studied Kent's Materia Medica, and the moment you study, somebody talks of a chamomilla child, a clear-cut a picture comes in your mind. And it is easy for you to recognize that kind of a child. Or you are talking of a sepia lady, and if you have studied Kent properly, or a sepia male also for that matter, the moment you talk of sepia and you close your eyes and a typical picture will come into your mind. And you will be able to recognize that individual better. Or you are talking of Macca, or lycopodium, or sulfur, or belladonna, or any of the medicines in Kent. See, then what he is doing is, and he was a master of this, he is not describing the symptoms, but he is describing the medicine as a living individual. And this has a very big advantage for a neophyte, no doubt about it. But it has also this disadvantage, which the previous level do not have. Medicines, knowing a medicine on the basis of drug provings or clinical symptoms does not have. That it creates an image in your mind regarding a particular medicine. So if that medicine comes with some other image, you will lose it. What happens is, you have an idea about chamomilla, right? Or you have an idea about sepia. When Kent talks about sepia, you have that indifference and the hip structure, etc., etc., etc. After pregnancy, after a lot of overexertion, or after a lot of having sex with her husband has forced sex upon her. In such a state, gradually there is this indifference and there is this stasis. Kent talks about. You will totally miss sepia in a calcarea carb type of physical appearance of patient. Fair, fatty, flabby. Sepia can be fatty also, can be flabby also, can be sluggish also. You will have a tendency to miss out. But there were Matia Medicas which are based on drug pictures and drug personalities. Now, from this point, at this point of time, so these had advantages and disadvantages. The next level which came was that since the individual as a whole is a patient, theoretically, that means the person who is representing the symptoms is a pulsatilla patient. So all of his symptoms have to be pulsative. That means within that person, there is a central theme, central point, which is the essence of pulsatilla. And from this came the mistaken idea of essences. Why I'm saying, and this idea of essences was given by George Vitulkas. Why I'm saying it was a mistaken idea? Because Vitulkas himself has said that this was not what he meant actually. This was a mistake. This was not what he meant. But since it has gone out very widely into the homeopathic world, and after that on the basis of essences, lot of other developments of Matia Medicas have come. But this is not how it should be. Yes. That is why I'm pointing out that the idea of essence came. Wherein Vitulkas in his stolen essence, he calls it stolen essences of Matia Medica. If you read his essences of Matia Medica, that was originally not his work. Those were his notes to a student who stole it and published it. That is why he calls it stolen essences. Where, for example, in case of calcarea phos, he talks of dissatisfaction as the essence. In case of midorinum, he talks of overstimulation, or he talks of giving himself totally, being passionately involved, being passionate as the central theme. This is a central theme which revolves around the whole medicine. So this was knowing medicines by essences. But actually, whether you have the right essence or not is very difficult to understand, because Vitulkas might be saying that, for example, dissatisfaction is an essence for calcarea phos, or dissatisfaction is an essence for other medicines. I might be saying that for chamomilla, the essence is not being cared for feeling. Now it has no meaning actually. So Vitulkas himself, he said from essentials it is better, because when you are prescribing on the basis of essences, they are bound to make mistakes. Because essences, according to each person's perception, might vary, and what is an essence to me may not be an essence to somebody else, and so there will be great confusion created. So from essences, the level was moved to essentials, which is a better idea. That means what are essentials? Knowing a medicine by a group of symptoms which are generally always present in all patients when all patients present that medicine. Almost always present. So this will be a group of important symptoms of those medicines. Maybe 5 symptoms, 8 symptoms, 10 symptoms. You are not giving less importance to other symptoms. But since it is very difficult to remember all symptoms, each medicine you are remembering by its most important symptoms. And these symptoms are the essential elements of that medicine. So that is how you know. At this group, if we study at drug proving group, Herring's Matia Medica was a classical example. If we study after the addition of clinical symptoms and development of drug personalities, we see 𝐀𝐜𝐮 Matia Medica and similar Matia Medicas produced at that time. Pulford, for example, M.L. Tyler belong to that group. On the basis of essence, Vitulkas is there. Then on the basis of essentials, on the basis of essence, a lot of people have, see, homeopathy has been contaminated. Up to 𝐀𝐜𝐿, homeopathy was not very much, it was contaminated, but it was not very much contaminated. But in the last 30 years or 35 years, this is what I feel, I may be wrong. In order to do something, in order to show my name, or in order to do something, I'm doing something for homeopathy. We have contaminated homeopathy to a great extent. And we have added absolute rubbish and garbage to homeopathy. To homeopathy, I mean to homeopathic literature. People speculate to that extent that romanticism, I mean, there was this so-called provings of marble, if you read, provings of boat, a shipwrecked boat, the wood provings from medicine, so-called medicine made out of a wood of a shipwrecked wood. Usme se potency has been prepared and it has classical symptoms like netromure. I mean, that's nonsense. Marble, yes, I'm not naming because I'm in a seminar. It's nonsense. Moonlight on a marble, and then you prepare something from the marble and you say this is going to cure all romantic individuals. Is not based on law. And all of this, we have contributed to this shit. We have contributed to this confusion. You are lucky. I mean, maybe many of you have been to stalwarts, to other schools of homeopathy which are existent in Calcutta, in India. Some of those schools, what they propagate is, I mean, unimaginable. Apparently, they say that we do great work. But if you do great work, then each and every member of your school should do great work. They don't. Interpreting rubrics. Now, this is going to be a topic if any one of you follows those kind, and there's going to be a heated discussion, and I'm always open to that. Interpreting rubric as, say, in Kant's repertory, light desires, interpreting it as a person who is knowledgeable, who has a lot of questions, is speculative. Is speculative. And speculation, it may work, it may not work. There was this seminar where I had gone to, and there was this desire for light or light desire for or something like that, and most probably stramonium and belladonna are listed there. And in a chronic case, the case which was being talked about was a chronic case, and they said that the patient had a lot of inquisitiveness, so belladonna was prescribed on the basis of this symptom, belladonna or stramonium, I forgot. And it was prescribed and it cured the patient. So I raised my hand and I said, that's why I have one question. Was belladonna only prescribed on the basis of this one symptom, or were there other symptoms, whatever, belladonna or stramonium, or were there other symptoms calling for this? Number one. And number two, by prescribing this medicine on this symptom only, have you failed at any time? So he said, yes, you failed. I said, sir, then I'm not ready to listen to your logic. Because even with this logic, if you say that desires light is equivalent to desires knowledge, and whenever the patient has this, belladonna is the medicine or stramonium, whatever, and it is going to work in all cases. If you have failed even in one case, then your logic is wrong, and I'm not doing that. Practically, I was thrown out of that seminar. Practically, I was thrown out of that seminar. Because, you see, what is, it may work. I'm not saying that it does not work. It may work in cases. But then you do ask that whether the other symptoms were belladonna or not. Because if the other symptoms were belladonna, even if this is not belladonna, this is cock bullshit, still the patient is going to get well. In homeopathy, when the most similar medicine is given, it is not going to fail. It cannot fail. If it fails, then know that it was not the most similar. So this going into essences is a very critical thing, and it can lead to, see, mathematical reading on the basis of essences is very good. Each person says something that 𝐾𝐜𝐲𝐜 is such an individual. It is very good to listen to it and it is very good to read, but it may not help you. So better is stick to essentials. What are the essentials of 𝐾𝐜𝐲𝐜? At this level, if you have mathematical, most of the mathematicas at these levels, at the levels of essentials, where you have, say, keynotes first. In many mathematicas, you have keynotes first, only keynotes. Then mathematica like Pulford, you have essentials first and then a descriptive description. So there are many mathematicas at this level. This was on the basis of essentials. Then on the basis of etiology, study of mathematica on the basis of etiology, including the miasmatics. When we were jumping with miasms, there were a group of individuals who would label a medicine strongly antipsychotic or antisyphilitic. All of us do this. But to prescribe only on that basis, to study a mathematica only on the basis of miasmatics and on etiology, is once again going to be a little bit of complicated thing, because in the first place, not a single mathematica has been written with this viewpoint on the basis of miasmatics. A theory of chronic diseases, if you see Hahnemann's chronic diseases, is one mathematica which has been aimed, that he has written psoric. But there also, if you see, he has described psoric, 𝐾𝐜𝐲𝐜 as a psoric medicine. But if you seriously study 𝐾𝐜𝐲𝐜, you will see a lot of antipsychotic medicines, antipsychotic symptoms also. Bryonia has not been discussed in chronic diseases. If you go home today and study Bryonia from Kent, study properly, you will see Bryonia has a lot of antipsychotic features. It has a lot of psychosis in it. So this is one way of studying mathematics. Study on the basis of states, dispositions, and circumstances. This is the next level. You see, we were talking on the basis of essences, right? Now, from essences, we moved to essentials. Okay. Now, what is the difference between medicine and a human being? The basic difference is a medicine, a potentized medicine, that is pulsatilla 30 or pulsatilla 200 or pulsatilla 1 ml. Within that one drop or 4 globules has the capability of transferring itself. On the other hand, an individual who is exactly like a pulsatilla. So that 4 drops in a way is that whole person. So if we study organon of medicine, we will see that he talks of disposition of an individual. Hahnemann talks of states of an individual and circumstances to all right. So studying materia medica on the basis of disposition, states and circumstances. Circumstances, so we say, for example, this kind. But no materia medica has been written on the basis of circumstances. One very good attempt on the basis of essentials and states and circumstances was done by, I'm forgetting the name. Who was the author of Divided Legacy? Unki wife, 𝐾𝐜𝐿. Catherine 𝐾𝐜𝐿. I'm sorry. See, I'm missing.
Harris School.
Yeah, Harris 𝐾𝐿 had written the Divided Legacy. Catherine 𝐾𝐿 has a materia medica where an attempt has been made to write at this level, and it is a very informative It's a very informative book. Where on the basis of circumstances and then disposition and states. Now, there is a difference between disposition and states. Unfortunately, no Matia Medica has been written at the level of disposition and states. And it is up to us, not me, it is up to you people who are attending this seminar, because I'm half dead now. I mean, my work, I'm already 27 years into the profession. God might call me the next day. But it is upon you generation to develop a Matia Medica which would be based on dispositions, states, and circumstances. Now let us just talk so that this might help. See, when you read 𝐾𝐻's Matia Medica, we have studied that pulsatilla has a mild disposition, has a mild temperament, has a mild disposition, right? Many places you will see that 𝐾𝐻 has used the word disposition. Many places in 𝐾𝐻's Matia Medica. Now, what is this disposition? Disposition, dictionary meaning is, it means a tendency to. You are disposed to, or you have a tendency to, which means it is showing your basic susceptibility, basic morbid susceptibility. This will be a central morbid susceptibility whereby to any of the stimulus, your reaction to each stimulus, depending upon the character of the stimulus, the reaction would be different. But the basic morbid susceptibility would be same in each of the reactions. So the reaction may be different, but in spite of the different reaction, you will find some similarity at a particular place. Yesterday we were talking about the speech. We are talking of quality and quantity of speech. This is something like that. In each symptom, the manner of reaction, in Hindi we also call it, sorry, in Bengali we call it probonota, the tendency to. Each medicine has a disposition. Now, in the pyramid, as you go up, a medicine has many common symptoms, has lots and lots of common symptoms. Then gradually when it comes to uncommon symptoms, it has relatively less uncommon symptoms. Then when you go to characteristic symptoms, it has even lesser characteristic symptoms. When you go to peculiar symptoms, it has even lesser peculiar symptoms than characteristic symptoms, because some of the characteristic symptoms are intensified common symptoms. So then, right? Then when you go up to circumstances, it has limited circumstances. Above circumstances, when you go, you are seeing the idea of a pyramid, the inverted pyramid. Above circumstances, when you go, you see disposition, where a medicine has a single disposition. Huh? Cancel कर cancel कर दे cancel is disposition. When you know medicine by disposition, and mind well, this disposition, it is not easy to know. The central thing, the essence or the essentials you might know, and that also is not very easy to know. If you study chamomilla, for example, the central theme of chamomilla, when you study chamomilla, make a note of this. Go to 𝐾𝐻 today and read chamomilla from 𝐾𝐻. At a particular place in between the line, very softly, he says that this feeling of neglect is the central idea of chamomilla, that I am not being taken care of. And you will see in most of your chamomilla patients, you will see, try it out in your chamomilla patients. In most of your chamomilla patients, this not being cared for is an underlying theme, is behind the totality. When you find this, you will see that the patient is presenting symptoms. Even if the patient does not have chamomilla, but if he has this theme, not being cared for. And this is not Dr. D.J. Sutawala saying, I have not contributed anything to homeopathy. I am not capable of contributing anything to homeopathy. This is 𝐾𝐻's contribution to homeopathy. If you read 𝐾𝐻's Mecca, where he talks of orphans, he's not talking of all orphans. He's talking of orphans born out of wedlock of clandestine coition. These are very deep things to think about. That means orphans who have been let go by their mother, a child who has been let go by his mother because the child was born out of wedlock. At the time of conception, the situation started. So in his case, in that child's case, this rejection phenomena will be there with everything. You will see this. So, see, because that disposition would be such, today suppose I'm a very depressed person. Then to every stimulus I would react in a depressive way. And I'm a very optimistic person. If I'm a very optimistic person, then to every stimulus I would react optimistically. If the wall falls down now, and if I'm a very optimistic person, I would say, "Arey, the whole Calcutta could have fallen down. At least the walls fell down on me, the other people are safe." So see, you will see that in all reactions. Similarly, this disposition is also a symptom. It is not that it is beyond a symptom, but it is a symptom above a symptom. And you have to learn to see the disposition of each medicine. This cannot be taught. So don't ask me the question that, sir, what is pulsatilla disposition? What is 𝐾𝐜𝐿 disposition? This you have to learn for yourself. This, while we are talking of this journey, this whole journey has to be done by the student himself. Nobody can teach him. None of the mathematics are going to teach. Your teachers, Hahnemann is going to teach you through Mathematica. Kent is going to teach you through his Mathematica. Wittgenstein is going to teach you through his Mathematica. Catherine Colte is going to teach through her Mathematica. Emil Tyler is going to teach through her Mathematica. Boring is going to teach through his Mathematica. All of them are going to teach. But the thing of essence is you have to learn. How much you can learn is dependent on you. The information is that you have to collect it and integrate it. But for that, you have to have an idea of what is disposition. Once you percolate into the ideas of disposition, you will see pulsatilla's disposition is a mild disposition. It means that to any stimulus, pulsatilla's reaction at any level, mental level, emotional level, and physical level, there is going to be a mildness. There is going to be a mildness. Now, how do you understand mildness in a pain? That is the question. The patient is shouting of pain. You have to learn to understand it. This nobody can teach you. I can tell you that this exists even in a pain. See, the pulsatilla pain and a belladonna pain. There is a difference. There is a difference. The pulsatilla pain is very severe, but it does not start with that severity. It's a gradually increasing. Comes gradually. Whereas belladonna, it comes suddenly. Belladonna, everything is sudden. So, this is very important. Disposition is a tendency to. So, it is a basic susceptibility, basic morbid susceptibility. And then, above disposition, you have a state. Now, state is, I don't know how to tell you. State is inclusive of everything of a being. As a human being, I am my susceptibility. My morbid susceptibility is mainly because of my miasmatic status. Yes. I have an additional so-called morbid susceptibility because of adverse circumstances. I have a healthy susceptibility which is dependent on my journey towards my goal. What was my goal in life? In the sense that I'm a 56-year male, or I'm a 58-year male. I've never felt a necessity to go to a prostitute. Why did I not feel a necessity? Whereas many people do. Why did I not feel a necessity? My friends, all of them were smokers. Many of my friends were drug addicts. Many of my friends during my college time, they were drinkers. They were drug addicts. I would go with them to the addiction, मतलब जहाँ पे drugs मिलता था, where drugs were available. They would take heroin and I would be sitting by that. But I never felt a need to take heroin. Why not? Why not? Because that is not my way of development. In my health, as a sickness that could have come in. But in my journey to perfection, whatever my journey to perfection, this life is, that is not a thing required for me. And a thing which is not required for me, I will not be susceptible to it. I will not be interested towards it. So I never felt a need to go to a prostitute. So the state I am in which at the moment includes my disease susceptibilities, which is due to miasms. It includes my disease susceptibilities, which may be due to maintaining causes. It will include my morbid susceptibilities, which are because of non-homeopathic medicines. And it also includes my healthy susceptibilities. And this in turn will decide my whole lot of circumstances in which I am. If you get a glimpse of this, then you see that state. Each one of us is in a unique state of development. At this point of time, Dr. Akshata is in one state. And if, say, Dr. X is there, he's in a different state. They may have so many common things. They may have common symptoms. But if the state are different, and each medicine, believe me, has a state. You can see a medicine, you can talk with a medicine. My teacher used to say, and he was absolutely right. You can talk with a medicine. You can make friends with a medicine. Is knowing medicines at the level of state. How do we know them, sir? No Matia Medica is written on the basis of disposition. You go through these Matia Medicas. Study these Matia Medicas. How to study these Matia Medicas? Professor Dubey, he used to tell us, he was our teacher. So he used to tell us that you should use chronic diseases and Herring's encyclopedia when you are not feeling sleepy, when you don't get sleep. He would tell it very jokingly that you read it and you'll fall asleep. सही है, chronic diseases पूरा ही घूमता चला. I'm sorry, the moment you read chronic diseases, you feel sleepy. No. The best way to study Matia Medica, to my mind, is you have to study all of these Matia Medica. So starting from proving symptoms, to drug personalities, to medicines of essentials, up to that point, medicines have been written. Matia Medicas have been written. You have to study everything. And you have to study all of this. From which you have to remove nonsense. How do I know what is nonsense? Keep on studying, keep on reading. There is no shortcut. I'll tell you how I used to study Matia Medica initially. Whenever a new medicine was taught, at those days, 𝐿𝑁 was unknown to me. In my first year, second year, 𝐿𝑁 came into my hand when I was in my first 2 years I did in diploma. And at that point of time, I did not know that there was a degree course. And after doing first 2 years in diploma, I shifted to first year degree. So when I went to first year degree, then I understood, then I came to know that there is a book called 𝐿𝑁. So first 2 years, I did not know even 𝐿𝑁 existed. So I'd asked one of my teachers and he had said, you read like this, you study 𝐀𝐜. So what I used to do was, I would read any medicine, new medicine which was taught in the college, I would go home that day and in one sitting, and I'm not joking, and nor am I lying, in one sitting, I would read 𝐾𝐜𝐮 𝐿𝐼 first. Then I would read Nash's 𝐿𝐼 if that medicine was there. Most of the polycasts in first year you are taught polycasts only. So they are there. So first I would read 𝐾𝐼𝐻, then I would read Nash, then I would read Farrington, then I would read Tyler, then I would read Cowperthwaite, then I would read Boric. And then after some time I understood that there is a medicine called Pulford. And then I would keep on adding 𝐻 I would read from all these 𝐻 and then I would sit for a while and think of all that I had studied and I would just write it down whatever came to me. And those were my notes for that medicine. Even today, I remember those medicines. There is no other way of studying 𝐻. Don't try any shortcuts. I will study only Boric. Fine, do it. Do it. Who is saying no? You will have to study each and every 𝐻. And each and every 𝐻 has a specific way of studying. When you study Boric, one of my friends, Dr. 𝐀𝐜𝐮𝐿, God bless him, he had taught me how to study Boric. When I was a very good student. So in final year, we were talking and he said, "Tum bada bada baat karta hai. You don't know how to study. You don't read 𝐻. I said, I don't read 𝐻. I've studied so many 𝐻. He said, study Boric. You don't know anything about Boric. So I said, how to study Boric? So the first day he told me, he said, you start from A and go to Z. That's all he told me. So what I did was, since I respected his wishes, I respected his talk, I went home and I started studying Boric from A to Z. And then when I reached C, I became totally confused and I went to him again. I said, Manoj, C, I reached till C, but I'm not remembering anything. I'm not remembering even the name of the medicines. He said, just do that. Remember the name of the medicine, that is enough. You should know that such and such medicine exists. Go, study. So I went up to Z and I remembered most of the names of the medicines and those polytests which I had studied, I knew some of its symptoms as written in the book. Then I went to him and I said, Z tak to ho gaya. He said, now read again. And then he said that now when you read Boric, you read with this, keep an eye on the italics of Boric, keep an eye on the conditions which is mentioning and read Boric that way. And try to tally it with your patients. That was the second time of reading Boric. Then when the third time I went, I added therapeutics. Boric has a repertory and therapeutics. We added that to it. And that way I went and I read Boric for 6 times or 7 times or 8 times. Today at times my students are simply amazed. When a patient comes to him and I say, oh, this is written in Boric, get me Boric, and we find out that, oh yes, it is written. I'm just verifying. There is no shortcut. There is no shortcut. The prescriptions which you have to make on generalities, you have to make on particulars, at times you have to make on miasmatics, at times you have to make on etiology, at times you have to make on pathology. So you must be reading 𝐻 on each one of this. Boric is a very good 𝐻 for small medicines, so-called unproved medicines, so-called specific medicines. You have to read them. When to use them? Am I going to use rampantly? Diabetes, if a diabetic patient comes, am I going to give him cesium? No. When am I going to use these small medicines? That I have to know, and that is what organon of medicine will tell me. When no clear-cut medicine is indicated on any other basis, and I have only the common symptoms to prescribe on, that is when I will use a specific, so-called specific medicine. And that too, with some amount of differentiation. Diabetes, you have a lot of specifics. You have gymnema, you have cephalendra, you have cesium. You can't use all of them. You see? So that is how you have to Matia Medica is a constant thing. You have to take, most importantly of all, what I would like to tell you at this point of time is, the way you take interest in your family members, the way you take interest in your children, if you have a child and she's doing something. Yesterday I saw a doctor who was seeing with a child. A child was sitting. Now, to that doctor, the way you take interest in your child, you have to take interest in medicines which you are studying. Unless you do that, what you see in your friend, the way you observe your friend, the way you deal with him, your approach with the medicine would be similar. When you are studying a medicine, don't think that you are studying something not alive. I challenge you and I assure you, one day with irritation read Bryonia, and next day with the sole purpose, with the interest of knowing Bryonia, you study Bryonia. You will learn two different things. You will learn Bryonia in a much better way. Learn लेके फिर स्पीचर लाइए बोला हम सेमिनार में. Learn to bow down your head in front of the medicine. We never bow down our head. अपना सर झुकाने में बहुत शर्म आता. Don't do that. Bow down in front of the medicine. Come, teach me, as we bow down in front of a teacher. Come, teach me, and the medicine will come and teach me. But there has to be no shock. And as you study more Matia Medicas, as you see more patients, things will develop within you. Automatically, you will understand the crying of chamomilla and the crying of pulsatilla, which we were talking yesterday. Yesterday, I was very much disturbed because at that point of time, I had to say that it's not coming from inside, because it was not coming from inside. That means I have not studied Matia Medica properly. I didn't show that disturbance to you, but yesterday night I could not sleep. Today in the morning, I got the answer that no, it was not that I have not understood. I understood some part of it. I have not understood many part of Matia Medica, but you people were not ready to understand that. And that is why it was not coming from within me. You see, the cries are different. They have to be different. Because the whole ego of the medicines are different. You have 𝐶𝐸𝐵 who has an aversion to injustice, but who has an indignation, has been abused. We had a 𝐶𝐸𝐵 patient who was physically abused by her uncle. She had told her mother that she was physically abused, and the mother said, "Chup, you are not going to talk of this to anybody." And even after mother saying that she was still abused by her uncle, with the knowledge of mother, can you imagine? And she had pent up rage she was in, and she had menstrual problems. Can you imagine the state of mind in which she is? And when I was reading her, at that, when we were talking to her, we didn't know that she was abused. It was as if I was talking to a 𝐶𝐸𝐵 individual. I didn't know that 𝐶𝐸𝐵 had abusing, and this was very early parts of my practice where synthesis had not yet come in. Synthesis has rubric. Abuse, sexual abuse, synthesis has a rubric where 𝐶𝐸𝐵 is listed. But this was before synthesis. I didn't know that 𝐶𝐸𝐵 had. But I was talking with this individual, and I was feeling I'm talking to a 𝐶𝐸𝐵 individual, and we prescribed 𝐶𝐸𝐵. We prescribed 𝐶𝐸𝐵 at 10 m. After 1 month, she comes and she's slightly better, and she says, "Doctor, I want to talk with you." So I and my assistant, we take her inside, and she had this catharsis. She had this beautiful catharsis where what she had not told to anybody, she told to us, that she was abused. And then, since this was a 𝐶𝐸𝐵 reaction, we used this as a clinical symptom. And in another patient who had this abusing and had other histories, We prescribed cephalosporin and we saw a beautiful change. And by that time, synthesis had come in and it has this amusing rubric where cephalosporin is listed as 3+. So this is how you add up to Matia Medica, and this is how you gain knowledge of Matia Medica. It has to be dynamic. And you have to study all Matia Medicas, irrespective of anything. I don't know whether I've made myself very clear or not, but this is how it has to go. And then when we come to the study of repertory, it is the same thing which goes. First, you have to know what kind of cases, what kind of repertorization are you going to do? What kind of philosophical approach you are going to do? One is a Kantian approach, which is entirely different, which needs other kinds of repertories, and the other is a Ħōmiophānian kind of approach, which needs different kind of repertoire. So in a given case, ideally speaking, at the end of case taking, you have to decide that whether you are going to follow the Kantian way or you are going to follow the Ħōmiophānian. When to follow, I can tell you that, because nowadays I don't use Ħōmiophānian, but there was a time when I would be using Ħōmiophānian. When in a given case, if you have more complete symptoms, more characteristic symptoms, go towards Kantian. But if you don't have characteristic symptoms, more of common symptoms and more of incomplete symptoms, that is the time when you use Ħōmiophānian. In such cases, Ħōmiophānian will help you. So first you have to decide on the repertory. The best repertory up to date, no doubt, is 𝐾𝐻 repertory, unabridged. 𝐾𝐻 repertory with corrections is a very good repertory because there is no contamination. Now, working on 𝐾𝐻, since 𝐾𝐻 said that generalities were important, so on the basis of 𝐾𝐻's repertory's generalities chapters, generalities, sleep, etc., mind, female, Berthel and Klüncker, they had made a repertory, synthetic repertory, and that was in 3 volumes, which consisted of generalities chapters of 𝐾𝐻. In the initial phases of my practice, and they added, there's a very good repertory to go through. It's only for those physicians who need a generalities based repertory. It was a very good repertory. Up to synthesis, everything has been put up into synthesis, right? But it was a very good repertory, and they added a very many rubrics, very good rubrics. So that was that. And then, of course, you have Wonderwood's, what is that repertory? Complete repertory. Yeah, the complete repertory. You have that. As against that, you have synthesis. We have been using synthesis, but using synthesis repertory, that is a problem. And this is problem which I feel, I don't know other stalwarts agree with me or not. Synthesis has different editions, right? Right now it is into 10th edition or 10th edition. Synthesis up to 7th edition is pure, is not very much contaminated. It has reliable data. But after 7, specifically in 9 and 10, there is lot of contamination. So if you are using synthesis 9 and 10, please use it with caution. That means whenever you are taking any rubric, it has a lot of medicines and a lot of authors have added, go to the author and actually find out whether that author has actually added that rubric or not, and whether that author is reliable or not. If Dr. D.J. Sutawala has added that rubric, don't go for it. Dr. D.J. Sutawala has not added any rubric in any repertory, but if you find that he has said it, don't go for it. He is not reliable. Go only for reliable stuff. Otherwise, you will end up with mistakes. Repertory, synthesis up to 7 is the best. Vitulkas is doing one thing which is very good. If you follow his Vitulkas compass, in Vitulkas compass you will see he's using only 𝐾𝐻's repertory, and to that he has added his own additions. So if you can find out 𝐾𝐻's repertory with Jugal Kishore's additions and Vitulkas's additions, that would perhaps be the best. But that has a limitation. it does not include certain interesting rubrics. For example, in 𝐾𝐻 separatory, I don't think you have injustice cannot be supported, which you have in synthesis. Right, and it is a very interesting rubric. So, working with synthesis, once again, study of repertory is something which each individual, I can tell you how I studied repertory, how I was made to study repertory. When my teacher, Professor M.M. Datta, he was teaching repertory, we had repertory classes from third year onwards, and nobody would do the class. He would come and nobody would be in the class, so he would walk off. But invariably, two of us would be there. Sorry, not from third year, from fourth year. Two students would be there. One would be I and one Oracle Kitty, we would be there. So then one day he said, "You really want to study this?" I said, "Yes, sir." He said, "Okay, do one thing. Go home and every day read 5 pages." That is how my study of 𝐾𝐻 separatory started. I said, "Read what, sir?" So at that time, I did not know what rubric was and what sub-rubric was. So he said, he opened 𝐾𝐻 separatory and he showed me, he said, these dark black words, these are called rubrics. And then below this are sub-rubrics, and below, under this are sub-rubrics. This is the language, this denotes a symptom. He showed me how it denotes a symptom. He said, just read this. Read the arrangement, in what way they are arranged, and just read them. So that was my first reading of 𝐾𝐻. 5 pages every day, I would read diligently. Once I finished that, I started again. Then I started seeing with the rubrics what were the medicines, and then comparing the medicines, and made a second reading of 𝐾𝐻, third reading of 𝐾𝐻, fourth reading of 𝐾𝐻, fifth reading of 𝐾𝐻, sixth reading, I don't know how many readings are made. And then when you see patients, automatically those rubrics flash in your mind. And automatic repertorization occurs. You have to prepare yourself. And of course, another way of studying is when you are discussing a case, somebody talks of a particular rubric, a particular symptom. Say, for example, more the flow, more the pain. As far as menses, immediately ectia racemosa strikes our mind from Bhatia Medical. It's better to see the rubric. Even today I do that. Even today I do that. Some strange looking symptom comes, or if I see a symptom which I have not recognized it, I go to the repertory and see the whole list of medicines which are in that. That increases your knowledge of Bhatia Medical. Repertory is a constant tool, but mind well, the problem is nowadays with computer, with laptop and tabs and everything available, it is better to have a software which will have a good repertory, and to have a good software. See, basically, there is one software which is Homeopath, which is a good software. And I've been at 44KR, we have been using Radar. I've been using Radar because I'm partial to it, because the previous editions had a thing called 𝐕𝐢𝐿𝐿 expert system, which is something unique, which is something beautiful. You know, it tells you how to select a medicine and it adds to your knowledge of Bhatia Medical. So I was very much interested. So that is why I've been using Radar. So I study synthesis, but the manner of studying repertories is the same. And then you have to also know about particular repertories. There is Malcolm's repertory of the tongue. Do you know? Milton's repertory of the tongue. Then there is Holcomb's repertory of convulsions, repertory of fever, of course, Ellen. You have to know this particular repertories also, because when you don't find symptoms in synthesis, say for example, you don't find a particular type of tongue in synthesis, then what are you going to do? You have to go to those particular repertories. So unless if I didn't know that Holcomb's, there was a repertory of convulsion by Holcomb, how would I go to repertory of convulsions in a case of, I have to know. So I have to know particular repertories. What is the way of knowing, sir? You have to 𝐵 catalog, which is very important. The work which they have done for homeopathic fraternity is tremendous. And today you can just search on the net. And most of those books are downloadable. Study, 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 and study. There is no other alternative than to study. I would like to add one thing to this study of Materia Medica. And the question was how it helps. How it helps, you never know. I will not be able to tell you. Because at weird times, in weird ways, it will help you. I'll tell you. Yesterday, I was talking about this sitting of 𝐾𝐜𝐻, that he sits down like a paunch, stuffs himself into the chair. This is what one of my students narrated. He stays around about 200 kilometers from Calcutta. So he was talking of his patient to once a year we go out. So in the vacation, during the vacation, he was talking to other students. He says that there's this patient who walks in and has a concentric hypertrophy of the heart, cardiomyopathy, and the moment he sat down, something struck in my mind, and then he started presenting the papers, and I could do nothing with the patient. I did not know anything about the patient, and I could not come to conclusion about any medicine after the case study. But that something was peculiar, was nagging at the back of my mind, so I sat back and I thought. And then what played into my mind was the way the patient sat down. And I remembered that in 44 KR, when I had gone to Sir, one patient had sat down like that, and Sir had shown me that, you see, this is how the patient sits, this is 𝐾𝐜𝐻. And not knowing what to do, so I gave 𝐾𝐜𝐻. And to my surprise, to his surprise that is, the cardiomyopathy got cured. To that extent, left ventricular hypertrophy resolved. After some time, left ventricular, there was no concentric hypertrophy. So he was telling other juniors that when you are going to the clinic, whatever Sir tells you or whatever Sir shows you, see it with. So how it is going to help you and where it is going to help you, you don't know. You have to keep all the information inside. Sometimes the hips of CPI, as it is mentioned in Kent, the narrow hip, she is more of a male. That is going to help you to see a patient. Sometimes the freckles of the telltale face of CPI is going to help you. What is going to help and how it is going to help, you don't know. But you have to take in the information. You have to take in the information and you have to integrate it within you. You have to make that information a part of you. The way you do not forget the name, your own name. Does any one of you forget your name? No. Similarly, you have to make a medicine a part of you, a part of your being. And when you make that medicine a part of you or a part of your being, it will not go away. When the patient comes, automatically it will strike. That, this was this. If you see toothpaste, you don't have to think that this is to be used with a toothbrush. So if somebody gives you, in the morning, the moment you take a toothpaste, you will be looking for a brush also. Where is the brush? Because those two go together. Similarly, if you have studied your medicines properly, the moment you see a patient, you will know which medicine it comes. It is like a key and a lock phenomenon. You know your keys so well that you know key in the garage, this is the key for the garage. This is the key for my house. This is the key of my cupboard. It is in the same keychain. But in the cupboard, you don't give your house key. In the garage, you don't give your house key or your cupboard key. You know which to use. Why? Because you know beforehand that this is the key. Similarly, you have to know your medicines. If you know your medicine so well, when the patient comes, the rest is going to be easy. Before ending, I would like to say certain things. I don't know what you people are going to say. Oh, we are already late. So thank you very much. For any person who needs me in the future, I'm always any serious questions regarding homeopathy. Just if I feel that you're asking questions for the sake of asking, or you are asking to let me know how much you know, I will not be interested, because I do admit beforehand that you people know much better than me. My knowledge is very less. So anybody has that problem is always welcome. I am. You can hook me up I'm there in Facebook. If you can get my emails, it would not be ethical for me to give my email or my phone number over here. It's not ethical because some of you might feel that I'm canvassing, which I'm not. So you can always find about my emails or my phone number with Dr. Akshata, and you are most welcome. At any point of time you need my services. But remember one thing, if at all you people feel that you have received something from me, then you owe it to give something to me also. Remember that, because I have spent time after you, and I have spent and the whole world, the whole universe works on a give and take policy, right? So to me, homeopathy is very serious. I mean, homeopathy is not a casual affair. So please be careful. If I am needed in future, please let me know. I rest my speech. Now, if I'll hear comments from you people, and then I'll be ready.
Thanks a lot, sir. It was really great to have you. I would like to ask the audience to raise their hands. So if any queries, we will take it in a quick time. Okay, please unmute Ojasvi, please.
Hello.
Vinod sir, there was a good session. I knew many new things. As I am a new practitioner, I just opened clinic 3 or 4 months back, and I am just learning each and everything from you and my senior doctor. I had a question. I follow 𝐀𝐜𝐮𝐿 sir, and there is a post on which he said that after 30 or 200 potencies, there are no interaction in between remedies. Is it true or false? I was just asking.
I'm not understanding your question at all, because I'm not familiar with the system. So I will not. What exactly do you mean after 30 or 200? Say you are given 𝐻𝐿 30 or 200, then
yesterday we talked about relationship of remedies by Dr. Miller, right? And in it there is anemical antidotes, remedies that follow well. So he said that it doesn't apply after 30 or 200 potencies.
if 𝐻𝐿, say for example, 𝐻𝐿 30, 200 is given in 30 or 200 potency, then
it doesn't interact with any other remedies which it antidotes or it is anemical for.
You mean to say that 𝐻𝐿 30 or 200, after 𝐻𝐿 30 or 200, if Ignatia is given, it will not produce any bad effect. That is what he says?
Yes.
Okay. Now see, to a certain extent I would agree with him, but not to all extent. You will see if you go through remedies, relationships, some medicine is there in a complementary group, and that is there also in antidotal group. So how can a medicine be complementary and antidotal at the same time? The logic is this, that the medicine does not harbor that relationship in all spheres. 𝐻𝐿 and Ignatia may be inimical in certain spheres, but they may not be inimical in other spheres. 𝐻𝐿 and pulsatilla are complementary in some place and they are antidotal in other place. So where 𝐻𝐿 pulsatilla is acting as a complementary to 𝐻𝐿, it will definitely not antidote. And where it is to be used as an antidotal, it will not be used as complementary. This is one aspect of it. But going strictly by the relations, you should, instead of going for the relation, prescribing on the basis of relations, one should always prescribe on the basis of totality of symptoms. Whatever the next medicine is, whatever the indicated medicine is, you should go for it. That is what I feel. in spite of relationship, because the relationships which Gibson Miller has given, that is also not a complete work in itself. You do not have relation of, say for example, Syzygium jambola. You do not have, so how are you going to work on it? It has to be worked upon. So the best way is always to stick to principles of homeopathy, that is to go by totality of symptoms. Okay.
Okay, thank you, sir. Thank you, sir.
Hello,
Verma
sir.
sir, now you can speak, please.
Hello. Thank you.
Yes,
Thank
sir.
you.
Yes, sir.
Dr. Saab, sir, can we make use of different repertories at the same time in a given case?
Yes,
Hello.
you know, can this becomes difficult. This becomes difficult. See, I'll talk of one of my cases where immediately it strikes me. You know, I was talking of Holcomb's convergence, right? So we had these people who were repertorizing on the basis of synthesis, and to me, 2 or 3 medicines were coming in, and I was not being in a position to decide in between 2 or 3. And then all of a sudden, see, these are repertories, these small repertories are repertories which you don't use every day, right? Then all of a sudden in my mind, this Holcomb's conversion came in, and I asked my assistant that what repertory lana to? And one of the rubrics which we could not find in any of the repertories was listed there, and it had a medicine which was within these 3 medicines which I was searching for. It had one of those medicines. So to us, that medicine became the indicated one. This is one way where you can use multiple repertories. And with synthesis, that chance is less, because you see, in synthesis, all repertories have already been included. Bodick's repertory, what Bodick has said in Bodick's repertory has been added. So in a way, when you are working with synthesis, you are already working with multiple repertories. When you are working with Kent, you are working only with Kent's repertory. But when it comes to synthesis, he has added everybody. Schroyuns has added everybody from Herring to Allen to Boningerson to Bogart to whatnot. You have an author list which runs into hundreds. So there you are not working with one repertory actually. When you go to synthesis, you are working with multiple repertories.
Okay, sir. Thank you, sir. Thank you.
Hello. Sir. Good evening, sir.
Yes.
Good evening. Actually, sir, I study topic was case taking. So, sir, how scientifically we will take case taking from mind? Actually, I am very much confusing to take mind, because Kent says one mental symptoms is equal to 10 general symptoms. That's why
don't generalize. Don't generalize. One may not be equal to 10 at times. One physical general may be equal to 10 mental symptoms. Not that. Yes. But yeah. So I'll tell you something. I'll tell you something. Now, what I'm telling is only meant for you. Okay, is specifically meant for you. I've not seen you. As you speak, what the impression which I'm getting for you.
Okay.
Try to slow down a bit in your life. Don't try to be hasty. Don't try to jump to conclusions very fast, and try to observe yourself. First, observe yourself, and then observe your family members and your friends. Learn to observe them. Over a period of time, as you first observe yourself, slow down, observe yourself in your entirety. Once you start observing yourself, then start observing others. Gradually, eventually, you will learn to see the mental symptoms. It will not come within a day. But for you, this will work.
So actually, what is scientific way to check down whether the patient is chilly or hot? Very simple question, sir, but very much important. Actually,
what is the scientific way? What do you mean by what is the scientific way?
Actually, correct way. How patient
Correct way is one thing, and scientific way is another. Correct way is one thing, and scientific way is another. I don't know. This hot and chilly is a very in what dialect you are using. I don't know how you would ask in Hindi or English, but in Bengali, what we verify is that what is the feeling inside you? Do you feel a feeling of heat, or do you have a feeling of cold? Not whether you are ameliorated in the heat or you are ameliorated in the cold. what is the feeling inside. The patient will say that I feel hot inside.
Okay.
Most of the patients confuse it with hot aggravation and amelioration. It is not to be confused with that. It is a subjective feeling of heat. That is why if you see which are hot medicines in synthesis, you have in the general chapter heat sensation of and lack of vital heat. That is lack of sensation of. So the heat sensation of people who feel hot in general, whatever language you use. And but don't go too much for this hot and chilly, you know. In evaluation of symptoms, always go from top to bottom. So if there is any other symptom which is more important than hot and chilly, then pay importance to that symptom.
Okay, sir. Okay.
Any other? Because see,
Sir,
it is high time and sir has given us so much extra time. I'm so thankful to sir for it. Any other queries?
Sir, one question. Sir, while prescribing for the patient, while making a case taking, we are just focusing on the totality of the symptom.
No, we don't only focus on the totality of symptoms.
Yeah. Okay, sir. As we are considering the total number of the symptoms as well as the one symptom that is a very what is called peculiar. And the complaint which patient is presenting, the only symptom which patient is presenting having a modality, and in spite the other symptoms having a different totality, and the totality it is varying. But sometimes we are not bound to, we are not prescribing on that totality, and we are prescribing on that peculiar symptom. So how, sir?
How can you do that? No. How can you do that? You can only prescribe. See, I understand what you are saying. No, when you are prescribing on the peculiar symptom, you never prescribe on one symptom, my dear. When you are prescribing on peculiar symptom, that is forming one important aspect of the prescription, but the whole totality of the patient. And totality is not the number of symptoms. If you feel totality of symptoms is the number of symptoms, you are far mistaken. Totality of symptoms is the gist of the patient, is what is showing you the medicine. Now, there one symptom, here Heading had said one thing, he had talked of a three-legged stool. He had said that at least 3 symptoms should support a medicine. If only one symptom is, he said, on one leg a stool cannot stand. On 2 legs a stool cannot stand. So there has to be 3 legs to a stool. This is the three-legged philosophy of Heading, where at least one symptom will never guide you to it can guide you to a medicine. See, it can lead you to a medicine. Triangular red tip, it can lead you to rust tox. But there have to be other rust tox symptoms in order to prescribe. The totality of rust tox has to be there. Otherwise, triangular red tip is there in other medicines also. You may not know it. I had a triangular red tip I had missed in a belladonna patient. I never knew, and I gave the patient rust tox. And then when the medicine selected was wrong, and I see the totality is there for belladonna. I said, but triangular red tip to rust tox mein tha yaar. Then I went into the repertoire and I see bloody red tip is also belladonna. And we prescribe belladonna. So you cannot prescribe. If you are prescribing for one symptom, you are not prescribing on the totality. You have to prescribe for the totality. The peculiar symptom, the characteristic symptom may lead you, may guide you to a remedy. But that it will guide you, it may guide you to another. In a case, you might see 2, 3 peculiar symptoms and 3 different medicines coming in. What are you going to do? The patient has a 4 to 8 p.m. aggravation. You are talking of lycopodium. He has itching, which is aggravated in the night, followed by burning. You are talking of sulfur, and it has great desire for eggs. You are talking in terms of calcaria. What are you going to do? You have to rely on the totality. There is no other way out. Those prescribers who prescribe only on one symptom, they are poor prescribers. What will happen is, in some cases you will get success, in other cases you will not succeed. Why you succeeded, you will not know. Why you have failed, you will not.
Hello.
Yes.
Hello.
Hello.
Good evening, sir.
Yeah.
Hello.
Yes.
Good evening, sir.
my-
May I ask one question, sir? Please, can you explain that as I am a government medical officer, I am now dealing with post-COVID complaint patients.
Oh,
So
yes,
please,
yes.
can you guide me that whether in such post-COVID patients, as
Wow, very interesting.
in
Very,
what way we should give
yeah,
important
very
to
interesting. What kind
totality of
of
symptoms?
post-COVID patients are you seeing actually? What kind of complications are you seeing?
Sir, specifically today morning, I am having 4 patients from one family. Father is having backache after post-COVID. Mother is having shoulder pain, and daughters, both daughters having weakness and dyspnea after small exertion.
Yes, 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 yes. This is very interesting. See, now here theoretically you can do two things. What we are doing practically, I will tell you. But first of all, theoretically you can do two things. One, the present symptomatology which the patient is producing, whether this symptomatology was present before COVID or not. That means whether this was a part of the original chronic disease or not. If this was, and if this has been aggravated, then first thing is to find a medicine for that chronic medicine. If you cannot find, then aggravated after acute disease, medicines like carbovate, sulfur, solanum, etc., etc., etc. You can think about lordoceresus, opium. You can think of those medicines. Right? What we have been doing
means only one rubric is there, aggravation after acute diseases.
Yes, that because COVID is an acute condition. So there you have to take in all those medicines, that group. Say carbovate, sulfur, solanum, lordoceresus, opium, and other medicines. My knowledge of materia medica is not very good. My knowledge of materia medica is very poor. But you'll have to take in all those medicines and see which medicine fits in the best. This is the second option. The first option is do a chronic workup and give the medicine. And then you will also have to take this weakness which the patients are having. Many a time the weakness is not because of COVID. Some patients are having weakness because of COVID, and some patients are having weakness because of the allopathic medicines which they are receiving during COVID. You have to learn to differentiate between these two. And then again, if you think that this is because of bad effects of allopathic medicines, treat accordingly to that rubric. 𝐾𝐜𝐿, Nux vomica, sepia, whatnot. You have a lot of medicines. This is very interesting. And in fact, post-COVID, many patients, we had one patient who was not having any blood pressure history, was absolutely normal. Post-COVID, his blood pressure is not going below 160/100 with antihypertensive medicines. We are seeing that case. We are given that patient Arnika. Let us see. I mean, if you contact me after a week's time, because I asked him to come after a week. So if you happen to contact me after a week's time, I'll tell you how the patient is after Arnika.
Sir, can I contact you even after this webinar? Because I am from Rajasthan, government medical officer, senior medical officer from Rajasthan government.
Whether you are government medical officer or not, it does not matter. It does not matter.
No, sir. Excuse me, sir. Because
you can contact me for any. Listen to me.
I am posted only for post-COVID center.
Wherever you are, for anything related to homeopathy. If you have a serious problem, if you have a sincere query, you can contact me at any point of time. Okay? Okay? You can always contact.
Thank you, sir.
I am always there.
Sir.
I think the queries can never
Hello.
end. I think we should.
Hello.
I think this will be the last query for the day, as I cannot exhaust, sir, with our queries because they are never ending. Sir, yes, you can speak, please. We'll take this last query for the day.
Hello.
Yes, tell me.
Hello, sir.
Yeah, tell me.
As a combination is available nowadays. It is beneficial. Second thing,
I will not answer to this question. I will not answer to this question.
Okay, sir.
I will not answer to this question. Do you think combinations are working following? Just a second. Do you think that combinations follow the law? They are following the laws?
No, sir. No, sir.
Then how can you ask me this question? We are talking of laws. 27 years, I have not prescribed a single combination.
Okay, sir. Okay, sir.
They may palliate a patient, but that is not homeopathy. And I'm here to talk only about homeopathy. I'm not going to talk on anything which I consider is not homeopathy.
Yes, yes. Okay, sir. Okay, sir.
Thanks a lot, sir.
Dr. Akshata, how come? I thought that you people were serious people. So how come?
Yes, sir. Even I never practice combinations. Agreed, sir, because combinations only palliate. So even I don't believe in any combinations to be there.
There's no question of believing. What is true is true.
Yes, sir. Absolutely. Our organ on. Right. Thanks a lot, sir, for extending your time and taking so many queries. If any other queries come up to me, I'll just ask you in personal, because I think we must end it for the day. Okay. I think all of us enjoyed homeopathy in these 2 days, and we will keep having sessions. Thanks a lot, sir, and thanks a lot, our audience.